actually happening to us. So that's the reason why we're having this session. Being over 35 has a lot of, it's just different. And one of the things we always say here at Supermamas, there's nothing wrong with aging. Every step along the way, we embrace who we are, how we are growing, even if, growing old is not something that we should be ashamed about. And menopause is one of the things that will get us along the way. Important for us to be empowered, important for us to have information, important for us to become self-aware. So on that note, allow me, it's exactly 6:38, to introduce Dr. Mutindi Kakuti, who will be our expert of the day, empowering us about menopause, being over 35, information in between. And at some point, we'll have a Q&A, we get to interact. So let's see how much we can learn and grow together. Ladies, I give you Dr. Mutindi Kakuti. Let's unmute and give her a big Yululations clap for her. Let us make her feel very, very welcome. Pamoja. Lucia. Well done. Daktari, over to you. Karibu, Daktari.
Wow. Okay, why are you not behaving yourselves? So I just want to welcome you to this talk. You can all hear me very well, Christina?
Yes, we can.
Okay, awesome. So I just want to return you back to a time called puberty to adolescence. So today we're discussing menopause. And it was a time when your hormones were raging. Ule kijana hapo kwa neighborhood, you were not even noticing him before. And now you're like, yo, who's this guy? When you became sexually active, your libido was crazy. You had perky boobs. Your metabolism, I was saying, is like a Range Rover on Mombasa Road. Pregnancy, pop. You gained weight and you snapped back, especially after pregnancy. And what else? So you could jog without knee pain. You could sleep comfortably under many covers, bila shida. Life was great. Then you hit perimenopause and you're like, ay, what is this? Hot flashes, night sweats, fatigue, you're sleepy, brain fog. You walked to the kitchen and totally forgot what you wanted. Nabado, menopause haijafika. But I want to reassure you that life is going to be great. So we talk about menopause. Menopause is about when your menses stop. So when a baby is being formed in the mother's womb, what happens is that there are like 2 million eggs in the beginning when the baby is being formed in the mother's womb, up to around 12 weeks. But by the time the baby is being born and by the time you reach puberty, there's a fixed number of eggs that we have, and there are about 500 eggs. So if you look at when you started your period to when you're going to reach menopause, you're probably going to release about 500 eggs or more, depending especially more on maybe family history and all that. So some people reach menopause later, others they start periods earlier, but the number of eggs becomes fixed. And so every month as you shed these eggs, at one point, the ovary will say, we don't have any more eggs. So you're going to be going into a season called perimenopausal, and then you're going to hit menopause. And so menopause is when you will come to me and tell me, I've not seen my period for over 12 months, but there's an age factor to that. So if you're above 45, we probably think about menopause. Less than 45, we wonder what else is making you not have your periods. So it's a gradual process. So when you start perimenopausal period, which can vary between 5 to 10 years, you start seeing changes in the body. So you might start seeing hot flashes, you might start seeing, your periods are getting irregular, amongst other symptoms before you actually reach menopause. And so this reduction in estrogen is what affects the different parts of our body. So you wonder, if it's only my ovaries that produce estrogen, then how come I'm having hot flashes? Where am I getting forgetful? Why is my vagina dry? Because estrogen, the receptors. So receptors is like when you have a fridge and then you want to you bandika a magnet on it. The fridge becomes a receptor. It shikilias it. I hope everybody here understands Kiswahili and maybe a bit of an official language. That if you don't understand, please let me know so that I can be able to, to help you to understand. So when this reduction is what usually causes effects of lowered estrogen in different parts of our body. So it's not just going to be the ovaries are affected. You find you're having brain issues, you're having other issues that we're going to look at, okay? So when we come to the symptoms of menopause, So the average age is about 51 years for most. It's around that area. So I think for me, the oldest woman I saw in menopause was 56, and she was so devastated. She's like, "Nataka kitu yache," and she's wondering why she's the only one getting periods. But it's different for different women. When we actually interrogated further, she started her periods much later in her 20s. So between the ages of 40 and 45, that would be considered early menopause. It's not unusual. It's just a bit early. Then those who are less than 40 years, that normally we call it primary ovarian insufficiency. Now, the word failure was used before in textbooks, but I think when you tell somebody your ovaries are failed, your PR is going to go down. So the word insufficiency, it means you have reached menopause before the time you're supposed to have reached it, and less than 40 is considered to be premature or primary ovarian insufficiency. So during the transitional phase, so what happens is before your periods actually stop, that 12-month period, what happens is you start going through other issues that are later on going to menopause. So you find your cycle is becoming irregular. So I'm assuming you're not on contraception, because remember, contraception really just changes your cycle altogether. So your cycles either become very short. If you had a 28-day cycle, it's becoming 24, 25. Then you find yourself having hot flashes. And hot flashes, I think, is the first sign in most women. About 80% of women, hot flashes is the first symptom they'll complain about. Then you're sleeping. You wake up at night. You find you're sweating because of this night sweat. You're pulling away your covers. And it's the middle of July. You live in Canada, Toronto, and you find yourself just, shoveling the snow, and you're like, I can't even wear a jumper. You've removed, you're wearing, a skimpy top because of the hot flash. And then you also have mood symptoms. So, I hope, I wish there was some men here, because for many women, they've shared that they don't understand what's going on. They are snapping quickly. And funny enough, you're snapping at the people who are closest to you. People say hasira na kujanga ule wale wako karibu na wewe. And then you find vaginal dryness. So you're not getting wet. I hope we can use a kind of language here just to make everybody understand. You find your lubrication is not the same. When you're having penetrative sex, you're like, hey, how come? But your mood is there, but your vagina is dry. Then the other thing that tends to occur is bone loss, whereby the density of your bones begins to reduce. You find yourself getting irritable. Your skin, when you had plump, nice brown, even if you're dark skinned, your skin is plump. It looks like it has water. It becomes dry. Your hair starts thinning. You find you have increased growth of hair on the face. You find you're gaining weight, and it's a particular area. So people like me, I'm sure I have sisters here who are like me, where your bodonk is like, you've got your bodonk and your snatched waist, even if you've got a pot. But now when you get menopausal, that fat kind of hangs around the tummy. And then you start getting joint pains, brain fog, memory impairment, and also reduced libido. All right. So when we talk about hot flashes is a sudden sensation of heat. It just comes on the face and on the upper part of the chest. And those of you, as Christina said, have sat with your aunties, July mumeva, jumper, you're wearing socks, you're cozied up, watching a movie, and it's cold, and someone is there above 45 fanning themselves. And it just comes like, like, I don't know if you've ever come from, like now it's very hot, and then you enter your car, your windows were up, and then you can't enter the car, and it's just like, that heat. All right. And it goes for about 2 to 4 minutes. Most of the time they'll occur at night. And there's also sometimes profuse sweating. Some people have palpitations. So palpitations whereby you're aware of your heart beating. And then after that, for some, they may feel like chills and rigors. So you may run to hospital, nimetoka Kisumu, this is malaria. And it's not malaria. You probably have perimenopausal. And then feelings of anxiety. You can imagine you're in a high-powered meeting, you are meeting CEOs, or like Christine is out there, and most of you who are business women are out there trying to conquer deals, and in the middle of the meeting you find yourself getting anxious because of the hot flash, and you feel embarrassed about it. Okay, so they mostly occur at night, and they normally say they stop within a few years. However, for some it has gone as long as 20 years, has been reported. Depression, I think, has been reported in some cases of people who are going through the menopausal transition. It would be more marked in people who have even prior history of depression and mood problems. And so this needs to be investigated, so you're not just getting treated for the perimenopausal symptoms and forgetting about that someone is going into depression about it. Because remember, this is a topic whereby if you tell somebody I'm going through this, utambua, it's like when you're a mom and you're talking to a fellow mom and they diminish the fact that you are going through something which is considered to be physiological and normal, and it's not. I think when we discuss further, you realize this is not normal, because everything about you changes. If your mood is changing, you're an extrovert, you find yourself becoming an introvert, you find yourself not wanting to go out because of how you feel. You find you're not feeling attractive anymore, you find you're gaining weight. So some of these things can come with depression, because if you don't understand what's going on, if you don't seek help, then you actually find yourself having depression. Then there are genital urinary symptoms. So genitals, it means the outside, our genitalia, that is the internal and external genitalia. Now, when we talk about genitalia, I realize I've separated the word vulvovaginal because many people confuse these two words. When people talk about how do you clean your vagina, then when I listen, I'm like, they're not talking about the vagina, they're talking about the vulva. So when you go to your doctor, the first thing that your gynecologist, they'll tell you, okay, you've told me what's going on, so can we examine you? And I think it's important that you should know how your gynecologist, especially who's a male, should handle you, and most likely tell you, no, kindly, you go this behind a curtain somewhere, you remove your innerwear, and then you lie on the couch, and then he'll tell you, well, we don't say fungua migu these days, it is open your knees, so that you drop your knees or just pat your knees, because if you see just migu, it doesn't sound very professional. And so what I will be looking at is the vulva. That's not the vagina, that's the vulva. So where there is hair, where you have the labia majora, the minora, that is the vulva. Then when I part the inner lips, then I'll see two holes. I'll see the urethra, which is the one for urine, and then the opening of the vagina. And that is now the entrance of the vagina. We are still not inside the vagina. And the only way I can look into the vagina is using that dreaded instrument called a speculum. So if you've had a pap smear or any gynecological exam, you must have had a pap smear. And I think I always say, if you've gone to your gynae, several times in a year, and they have not looked into your vagina, you need to change your gynecologist. So what happens when we talk about atrophy is shrinking. Now, remember, even when the vagina shrinks, it's not the shrinking you wanted because maybe you had a baby. Imagine it's shrinking and then it's dry. So these changes normally really, really cause a lot of women a lot of low self-esteem. And this is because of lowered estrogen. So you'll understand estrogen is such an important hormone, but we all have to go this as women, God willing, we reach that age. So these symptoms develop later than other menopausal symptoms. So you find atrophy, and whereby the shrinking of the organs, the external organs, even the uterus, it can shrink to the size of a thumb from the size of a pear. And then so this also leads to decreased blood flow. So remember, when blood flow reduces somewhere, for us in medicine, is also the lubrication. The oozing out of water or wetness also becomes reduced. Okay, and this also is, but the good thing about this, it's very responsive to estrogen therapy. So we'll talk about HRT later on, and the myths about it and the scary things about it. The other common thing is urinary incontinence. So you're sitting with your friends, mnapiga story, then you laugh, and then boop, a little bit of urine has come out. And you're wondering what's going on, and I've been doing my Kegels. Now, remember, again, because of lowered estrogen in the body, then the muscles, all that area, the pelvic floor, the one we tell you to exercise. And I think someone like Christine will tell us about the exercises she's doing in terms of, especially age-related exercises, to help build that pelvic floor. So that also you don't have uncomfortable sex. You find yourself having urge incontinence. And urge is whereby, so you're in the supermarket, you feel like peeing, you're like, okay, I can hold it until I get home. You reach home, you're at the gate, and you just find it's actually passing through. And I remember my mom, one time I opened the gate after her and I busted my mother. She's late, and we have a beautiful grass garden outside. And I was saying, this grass is becoming very green, because she'd say, I can't hold my urine, so I'll just be outside. Yeah, when I've press the bell and you guys are not opening. All right. So those are some of the issues you're going to face. And the good thing is, now in Kenya, we have people who are highly specialized in managing these small areas. Then we have vaginal dryness and friability. So you find yourself, if you're not lubricating, so if you're not lubricating well, then you have to use an alternative. Then that means if you don't use it and you're very dry, and I'm not going to say all men are rough or they can understand, but sometimes some women would say, saa zingine akiingia hapo akienda safari, he's going to Mombasa, he's in a Range Rover. And I'm like, please, let's go like we're in a Vitz tufike hapa Machakos kwanza, So those are the things that women will struggle with in gender urinary changes. Then, so I've talked about the perimenopausal period. And so the people we are normally concerned about are the people who are less than 40. And then between 40 and 45, we can do some investigations to find out what's going on. Now, if you're on contraception, it becomes a bit tricky because as long as you have your ovaries, this is for women who have ovaries. Now, if you've had surgery where your ovaries were removed, then that's very different. So if you were on contraception, remember, if you have ovaries, even up to the age of 60, 70, they will respond and you're going to get a period when you're changing over your pack. So remember the contraceptives, like if you're taking the oral contraceptives, they normally change your cycle. All right. So when they're changing that cycle, I mean, they give you a cycle. So when you're perimenopause and you have your ovaries, they are still responding. And that's why when you're going for surgeries like, hysterectomy, some of you have had fibroids, and maybe I'm sure some of you maybe here have had a hysterectomy. So one thing is we try not to remove the ovaries unless it is necessary. And, like one of my aunties told me that, her ovaries were removed. And I called the doctor. He said, oh, she was 55. She didn't need them. That little estrogen being produced by the ovaries that are there is so important, so that when we are giving you HRT, hormone replacement therapy, we're not also giving you higher doses. We're giving you a lower dose because the ovaries are also kind of helping us in a bit way. All right. So from perimenopause, and you have the drastic changes that go into menopause. Now, for those who want to conceive, there's a hormone called AMH. If you're above 35 and you've gone to hospital because you've not been able to conceive, there's a hormone that is called AMH, anti-Mullerian hormone. This one is normally checked, and normally it checks ovarian reserve. Remember, I said we have a fixed number of eggs that we have to ovulate up to the time we reach menopause. And so as they keep producing, these AMH levels continue to go down. And so when you combine low levels of AMH, then and someone who's above 45, then and they're asking you, am I in menopause? You can say yes, actually you are you're in the perimenopausal period. If you're still getting periods, you're going into perimenopausal. And then now for those who are less than 40 years and 45, you want to do the FSH levels. Now FSH is the hormone that begins the menstrual cycle. So when you have your period, the next cycle, FSH is telling the ovaries, let us start making an egg. Let us start preparing an egg that will be ovulated either to conception or you're going to get your period, okay? Then also testosterone, so which also is responsible for our libido, together with estrogen, goes down. But the decline in estrogen usually is more than whatever that of testosterone. Then, so what are the long-term consequences and risks? So people are at risk of dementia, and I think most of you watch Grey's Anatomy. Remember Meredith Grey's mother, and she had to say, I want a genetic test to confirm, and they're very expensive, so we don't have to do them. I think we'll talk about the ways that you can prevent this from happening. And then heart and circulatory problems. So if you're at risk of hypertension, diabetes, then this also become exacerbated during menopause. But it's not for everybody. And as we discuss lifestyle changes, then you'll understand that. Then you have bloating. You find you're getting constipation. Your bowel movements are irregular. Then you start getting bone aches. Your bones, if you fall, your bones fracture easily because estrogen is protective to the bones and makes your bone mass density, meaning the bones are stronger when you have estrogen. And then when this is withdrawn, you find you're losing bone mass. And so sometimes you have to go for a scan to tell us if your bone mass density is normal. Then some people are at risk of endometrial cancer. So even as we put women on hormone replacement therapy, we have to be very careful about those who are giving these drugs to. Right. So bone loss, this begins during the premenopausal, perimenopausal area region. And it's interesting, we'll discuss nutrition. Actually, the higher the body mass index are, you actually have slower bone loss. So one thing you want to avoid when you think about weight loss is avoid malnutrition. Avoid malnutrition. Don't get too thin on a particular diet or meeting particular food groups because you want to lose weight. What happens is you're actually going to lose more bone mass. All right. So when we're evaluating these patients, what we say is, are you above 45? Are you 40 or less? So if you're less than 40, we need to investigate further. Why have your period disappeared? And so we normally say if your periods disappear for 3 months or more and you're less than 40 years, then there's a problem. But the first thing we have to make sure is you're not pregnant. We've gotten some shocking, interesting cases. There's a lady who she was using the coil, then she went for 6 months without getting a period, and we had not confirmed she's menopause. So she went and removed her coil. She actually reached out and pulled it. At 47, she got pregnant. So there's some surprises, you just don't want to have. And that's why we are here to help you. Then if you're above 45 and you come and tell me, my periods have been irregular, I'm getting hot flashes, I'm feeling like this, then we start saying that this could be perimenopausal. So if it's more than 12 years, we say you're probably going through menopause. 12 months, you're probably reached menopause. If it's less, then you're in the transition. But if you're less than 45, you're between 40 and 45, then other hormones need to be checked. There's a gland in front of your neck called the thyroid gland. And we want that gland controls a lot of the metabolism. If you're hyperthyroid, then actually your periods disappear. If you have high levels of prolactin, that one is PRL. PRL is a hormone that is produced when you're breastfeeding, and that's why you can hear people saying, if you're breastfeeding and telling you're breastfeeding every 3 years, your prolactin levels are so high such that you don't ovulate. But we don't play with that one. We just tell you use contraception for 6 weeks when you're ready to resume intimacy with your partner. Then also high levels of FSH. So we don't also just make assumptions. We have to consider, how old are you? What else has happened to you? And we take a detailed history. But the first thing, when your period disappear and you're less than 45, we are going to ask you if you might be pregnant. And sometimes it's a fight to convince you to get a pregnancy test. And we have found women who found themselves pregnant and they didn't expect it. So of course, those who are less than 40 years old, they need more evaluation, because we need to confirm that they have reached menopause. And now sometimes FSH is very expensive. To do the test, I think for some labs, between 25 and 4,600, or even 6,000 if you go to places like Aga Khan. And it's not, so for that age, you may need to have to do the test. But the first thing I'll do is, take a good history and ask you questions about, have you had surgery? Have you had chemotherapy? Have you had a radiotherapy? Because these modalities of treatment for cancer patients, then they do sometimes cause a premature ovarian insufficiency. So when we might give you pills and say, let us give her pills. So we'll first give you progesterone, and then you take them for about, 21 days. Now, if you don't bleed, then I'll be like, let me check if her ovaries will respond to estrogen. Then I'll give you both estrogen and progesterone, or estrogen alone. But most of the time, because the pill is cheaper, then we give you both estrogen and progesterone. If you don't respond to that, then I have to do FSH levels, look at prolactin levels, look at your thyroid levels to ask myself, why is this patient not having her periods? And also she's not pregnant. The youngest patient I've had who actually had menopause, and we had totally unexplained menopause, was 24 years. And those are very rare cases. So I think we've talked about how to diagnose. I'll skip that slide. And we've talked about age factor and how you diagnose these patients. All right. So we're going to ask you, are you on contraception? Remember, if you're taking, let's say, like progesterone only contraception, now remember, contraception behaves differently for different women. There are those who are taking the Depo-Provera. There are those who are taking the implant, the one for 5 years Jadel, the one for 3 years Implanon, or it's called, I think, Nexplanon. And some people don't get periods at all, and it's okay. By the way, it's considered to be a side effect, but it's not a bad side effect. So when even you go to your doctor and they tell you don't worry about it, then it's okay. Some women will say, no, I want to see my period. So if you're on contraception, remember, contraception does interfere with the menstrual cycle. So we want to make sure that iron contraception, we may have to stop it and then choose particular days. Like we'll say, stop your contraception, get your period, come on day 7, we measure your FSH levels so that we can be sure. People who have polycystic ovarian syndrome, we are seeing a lot of young girls, maybe some of you have a daughter or sister, someone who has polycystic ovarian syndrome, and they have irregular cycles. They can get, the rule is they get less than 8 cycles. Others, it's 4 or 6 cycles in a year. And when their periods come, they are very heavy. So we are like, hey, if you're between 40 and 45 or less than 40, is this menopause? So you have to be investigated. If you're diabetic, hypertensive, and overweight, and you have any abnormal cycles, especially heavy bleeding, which is abnormal, you must be investigated above the age of 35. Please take note of that, because I think many of you have gone to hospitals and seen, maybe even some of my colleagues, and an off cycle, and you're told, oh, it's normal, don't try to go back to normal. Remember, if you're overweight, hypertensive, diabetes, and you have any irregular bleeding, it is important that it is investigated to rule out endometrial hyperplasia, which means the lining of the uterus, those cells that bleed, we want to make sure they're not, it's not thickened, because that's a precursor which is associated with uterine cancer. All right. So we come to what happens when you've had a hysterectomy. So some women have gone through hysterectomy. So what happens if you remove the uterus, even if I remove it at 35 or 30 because of fibroids or maybe cancer or maybe another medical condition, then you are not going to get your period, but you've not reached menopause because your ovaries are still going to be ovulating if you've not removed them. So for these patients, you're not sure have they reached menopause or not. So it's important, maybe you may have to do FSH levels. And remember, it's called follicular stimulating hormone. Follicles meaning the eggs, where the eggs live, and then stimulating. So it's the one that begins the menstrual cycle. And then when that egg is identified, estrogen is produced, then there's ovulation, then other two hormones. If you get pregnant, progesterone continues supporting your pregnancy. If you're not pregnant, progesterone day 21, it drops, and then you get your periods. If I'm going too fast, please let me know, okay? So what's the management? One is to reassure the patient. It is a physiological process. It is a journey. And for me, I tell my patients, you're okay and you're going to be fine. But we need to also figure out, I can't say, oh, it's normal. This is life. And the layer two, you'll be okay. This patient needs to know I'm going through this, because many people, it is disruptive to their quality of life. There's a way you are living. You're in meetings and you're not struggling in meetings. You're not struggling with brain fog. You've not gone to a grocery store and parked your car and then go back home and you're like, what they even go to do help. Please, there are those who tell you it is normal. Like stop being a simp about it. Stop wacha kuwa babi about this. It can be very disruptive. I have seen women who, and we've talked about things like depression, we've talked about low self-esteem, we've talked about sexual problems. So it's important that even as we reassure you, we are also trying to help you based on the symptoms that you have. Support groups. Let's get together. When we're talking about baby showers and had bridal showers, we had the babies. So what do we do now? Let's get together and talk about menopause. Okay, so talk about it. And another important person needs to be in this equation is your spouse, because you may not even realize, for example, if you're getting irritable or your mood swings. Some women, maybe depending on the community, you're not very empowered in terms of saying, the sex is painful. So involve your spouses or your partners as soon as possible. And then also the important danger sign we discuss with women, of course, is any bleeding after menopause. So remember, you've gone 12 months without a period. Any bleeding after that must be investigated. Anyone who tells you it's normal, it's not normal. Secondly, do not allow a gynecologist to remove your uterus before confirming that you do not have cancer. That means you need to go to theater and then they do a procedure which just takes a day. You go in the morning, in the evening, you're out. They take samples, they scrape the lining of the uterus and put a scope that has a camera, and they look inside and collect samples from the uterus. And then they can say, okay, this is all right. So that you don't have to remove the uterus if it's not necessary. There's no cancer, leave my uterus alone. I think it's been very sad that some, I've had patients who, you ask them, you had a hysterectomy, when they say, I was having bleeding after menopause. Were you ruled out cancer? And they say no. And the guys who actually are cancer specialists in Kenya are saying they are seeing women coming with cancer after the uterus was removed. So remember, as a patient, you have a right to interact and question your doctor. Do your research and go and, even if you're going to Google, yes, some doctors don't like Google patients. Please just make sure your doctor is somebody who says, I want to clarify that, or I agree with that, or they can even bust some of the myths which are on social media and internet. All right. So the other thing also is continue with your breast and cervical cancer screening. Oh my God, please do not stop. So cervical cancer screening stops at 65. Breast cancer continues, I think until 70. So please do not stop screening. Just because your periods have stopped, these two cancers aren't related with your periods and menopause, you can still get them. And so it's important to continue getting screened. All right. So how do you prevent osteoporosis? This is the thinning of the bones. So one is an optimal diet. And I wish I said this in bold: avoid malnutrition. So I think some of you knew about what was this diet? It was a famous diet by some celebrity. Someone remind me, Fat Loss Lab. Now, you are taking about 500 calories. That is not the calorie intake any human being requires. So what happens, you're going to get rapid weight loss. But in menopause, it goes against you. It goes to your disadvantage, because remember, the lower your body mass index is, the more you lose weight in such drastic ways, omitting certain food groups, what happens? You're losing bone mass. So every food group is important. What you need to do is choose the type of food group that you need. So work with, there are many nutritionists who, I wish we had one today who could give us a small talk. Maybe Christine, you can organize for that, because nutrition is important. All right. But of course, now you have to make sure that you're not eating. I guess you may not be able to eat the way you were eating before, because your metabolism, oh my God, it's like a Vitz climbing up Mount Kenya. So you need to make sure that you are including all food groups. And I think most nutritionists will say the trick is, when you have a plate, and it's not this big lumina plate you're served for food in a wedding, half your plate is veggies, and then half your plate is protein, and then half your plate is vegetables. So for example, if you want to have R&B, rice and beans, you are totally, those are both, beans are starchy protein. So you're taking a starch, another starch. So nutritionists will teach you how to come up with a meal plan that helps you to, and especially building muscle. So whether you're going to have a low carbohydrate and high protein diet, that's fine, but do not omit all food groups. When it comes to fruit and vegetables, that's where your important minerals and vitamins are. And minerals are so important, especially for building hormones. Do not omit fats. In fact, if you're the guys who can afford grass-fed butter, like for me right now, I've changed to cooking with ghee. I'm no longer using the normal vegetable oils. I thought animal fats were bad. They're actually good for you compared to buying the oils that are commercially sold in the supermarket. Even butter is not as bad. Not everything is bad, but just make sure you're taking it in proper amounts. All right. So calcium. Remember, calcium helps to build our bones. Vitamin D, take that walk outside, and especially between 10 and 12, that's the sun for vitamin D. Some people may have to go on supplements. Remember, some of us, the jobs is you leave the house at 5 p.m. You go into your office, you don't leave the office, and then you're leaving the office at 7 p.m. You have not met the sun at all. So you may need to take supplements, and those are important. The other thing is, and I think the dietary intake, they say you should take about 1,200 milligrams daily of calcium. But if you're able to track your calcium intake, then you don't need to supplement. And I think there are many websites that tell you, if I have a cup of spinach, this is the amount of calcium I'm taking. If I take yogurt or milk, this is the amount of calcium I'm taking. Whether you want to take milk or not, whether dairy products or gluten-free, that's really a personal preference, because not everybody is lactose-free. Not everybody is affected by lactose, or not everybody is affected by gluten. My father is 85. And goodness, the guy has no issues, no problems. And I don't think it's any different for women. So diet is not really, it's just, I think, knowing what to eat and a healthy diet. Weight bearing exercises. And I think I had Christine talk about this before, is as we grow older, please cut back on the cardio and increase the strength training. Now, remember, for you to have good heart health, you need to get that heart going. So they say about 15 to 30 minutes, 4 times a week, make sure your heart rate is going. I think there's a level they say above, I think 70% of your resting heart rate. So if your heart rate, I think, is at 80 and you want to work out and make sure your heart is really beating, then you take 70% of that heart rate and make sure it gets above that, or even just above 100 for about 30 minutes, 4 or 5 times a week. But importantly is strength training. Why? When you build muscle actually burns fat. So that's one thing that's very important. If you've had a recent fracture, and especially if you're at risk of fracturing, then of course you might need a different type of therapy to facilitate building your bones. And then you talk about sexual dysfunction, vaginal dryness. You have low libido, painful sex due to vaginal atrophy. So this is not the vaginal atrophy, the thinning whereby people who go and get Botox, or people. I've had patients who, when I deliver the baby, they say, make sure you rudishate, it becomes small. I've had patients say they want to want elective remove excess tissue. This is not that. This is literally thinning, and it's actually more, it's not the same thing. Then you have low self-esteem. You can imagine you're not interested in sex and you really enjoyed it before. And all of a sudden, of course, your partner is also getting frustrated why you're denying him sex. Remember, the pelvic floor becomes loose. And that's why also things like you find your bladder prolapsing. For women who've had difficult birth or given birth to very big babies, you may sometimes realize if you put your hand in the vagina and you're pushing down, you feel like there's a ball or something coming out. We've seen patients whereby their uterus was literally halfway out of the vagina because the muscles that keep all those organs up are a bit loose, okay? Then, of course, diminished lubrication. All right, so what do we do? So one thing is, this is where now HRT and hormone replacement therapy comes in. And it's important because I think if there's one part of the body that responds to particular sexually dysfunction is using hormone replacement therapy, and we'll talk about that. So even others have to use androgens. So there are patients who you cannot use hormone replacement therapy, and patients who've had breast cancer, uterine cancer, ovarian cancer, certain cancers associated with excessive estrogen, you cannot use hormone replacement therapy. So you may have to think about alternatives, and your doctor can prescribe them for you. So androgens are male hormones, testosterone. So you find your libido is low, and we may say, let's give a testosterone. But you might find now testosterone doesn't help in managing, let's say, hot flashes or any other problems. All right. So the other thing is also lubrication, things like KY jelly. I've had patients, especially Asians, using odorless, light oils like coconut oil, sweet almond oil, and which have been suggested, and patients have not complained about any side effects. Of course, a healthy diet and weight loss. You can go for sex therapy. I do not know if you come on manani, but just go to, there are people like Dr. Joachim Osur, and there are many other even sex therapists who are psychologists who can help you, and especially your partner, to understand what is going on. One thing is to avoid stress. Even now, even now before you reach menopause, remember, stress can be a mood killer. All right. So the other thing is showing that yes, testosterone has helped in a controlled dose. All these things, we start them in very low doses until you're able to tolerate them and get your life and your mojo back on. Then primary ovarian failure, the one with, if you go into menopause before 40, can be caused by chemotherapy, radiotherapy. You may have a tumor, and the ovaries have to be removed. Sometimes unexplained genetic disorders, and also it can happen in families. So if your mom, your family side started the periods early or going to menopause early, it may happen to you as well. Now you can imagine you have an 18-year-old, 24-year-old, she's gone to campus, she's not even gotten children, and you're telling her, you've got an ovarian tumor, it's cancerous, we need to remove your ovaries because this is life-saving. So they need a lot of counseling. It's very sad news, and quite devastating for them. So one thing now in Kenya, you've all got to know that's happening now, is if you know anyone, and especially has a young, daughter, or, young woman who's going through cancer and has chemotherapy, therapy, these days they can harvest the eggs and they can be stored, and you can have your babies much later. And actually, if you still have the uterus, you yourself, even after cancer, can actually carry your own pregnancy. All right. So for vaginal dryness, I think you notice with the vaginal dryness, some people also get very watery discharge. It's not candidiasis. It's not the thick, like yellow creamy one. It's just a watery discharge, and it's called leukorrhea. And really, it's not known what happens. We've talked about frequency and urgency of urination, and of course, one thing is discuss with your gynecologist. Please, when anyone tells you, oh, it's normal, this happens to me, you go to your doctor. Let your doctor tell you this is normal or this is perimenopausal. Okay. The other thing is we have pelvic floor specialists now in Kenya who actually treat incontinence. Before, you'd have to go to India, or some people go to South Africa and get Botox. And right now we've got doctors, I think like Dr. Sule, Dr. Were, these are my colleagues, and they do Botox for people who have incontinence, whereby they just need to give a shot and just kind of like narrow the neck of the bladder so that now you're able to hold your urine properly. Others may require surgery whereby you need to lift up the uterus or lift up the organs that have prolapsed, even like the rectum and the bladder. Of course, make sure you're doing your Kegel exercises or Kegel exercises, weighted pelvic thrusts, butt crunches, and all this. When you have a weight on them, you're creating resistance. So these actually have been shown to kind of help with urinary symptoms as well. All right. Hot flashes, we say lower the room temperature. You can use an AC or fan, or just, in Nairobi, leaving your windows open, depending on when you live, you're going to have mosquitoes, all over you. Light clothing, less covers, hydrate, 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 avoid stress, limit spicy foods, but because this may trigger some people, others, they don't have a problem. Especially if it's something you take often. Lukewarm to cold showers are great. Sometimes I think I've worked too hard to take lukewarm showers, but since I've not reached menopause, I'm sure that may change when that happens. For those who have very severe symptoms of hot flashes, then we'll talk about hormone replacement therapy, and which contraindicated, whereby you can't give them, sometimes you have to give them antidepressants. And a lot of research has shown some drugs. So some drugs, the company doesn't say it's for hot flashes, but a lot of research right now is being done so that they can be labeled as medication that can be used for hot flashes. Some anti-epileptic drugs are very beneficial for some people who are going through hot flashes, and especially when the hot flash is very debilitating to you. Tibolone is an old drug. I think in Kenya, it comes and disappears. It has synthetic estrogen and progesterone, and also testosterone properties, and some people say it helps them with menopausal symptoms. So also has a benefit on bone mineral density. Let me take some water, please.
Meanwhile, as Daktari is sipping some water, let's keep the questions coming through, and then I'm sure at some point in a few minutes, we're going to feed the questions. We'll open the floor. You are new to get to ask your question, then we can continue to be empowered. Daktari, you okay?
Yes, I'm fine. Thank you.
All right, back to you.
All right. So now we talk about hormone replacement therapy. So a lot of women have said, I've gone to the doctor, I'm having these symptoms, and and they are perimenopausal or menopausal. Sorry. So what happens is, even perimenopausal women, you go and tell your doctor, I'm feeling this way, and they tell you, you're too young, I can't give you hormone replacement therapy. But and you have debilitating symptoms, and we know it's menopause or perimenopausal. So there's been the debate. Can women who are perimenopausal, who have severe symptoms before menopause, take HRT? The answer is yes. And over the years, hormone replacement therapy drugs have actually improved such that they have become safe. Are there risks? Yes, we'll discuss those risks. Right? So it's either called hormone replacement therapy or menopausal hormone therapy. So that's a UK term, and the second one is a US term. All right. So the benefits actually outweigh the risk for the healthy. So a lot of people who are less than 60 will benefit a lot if they don't have a contraindication, meaning they don't have another problem that limits them from taking hormone replacement therapy. Let me use the word HRT. Then they can actually take. Now, so there's a study that was done in the US. I think it was called the World Initiative or Women Initiative something. And so this study caused a lot of uproar, because it said that, yes, if you take HRT, then there's a risk for you for getting breast cancer, ovarian cancer, of you getting blood clots and all these things. Now, the study was done between women who are 50 and 60 years old. So that's where the catch was. Most women, between 15, I think it was between 59 or I don't know which age it was, but there were women who were not even candidates for hormone replacement therapy. So over the years, the teaching has changed, and we are seeing that it is beneficial for you to take it if you do not have any risk factors that make you, that the doctor would say you can't take it. So if you have a history of breast cancer, if you've had coronary heart disease, meaning a clot in the vessels in the heart, the one you hear people saying heart attack, someone is holding the left side of the chest, or a myocardial infarction whereby there's a clot, or there's a fat plug, then other people are okay using. If you've not had previous pulmonary embolism, whereby you have clot in your lungs or in your heart, or whereby you've had DVT, DVT, deep vein thrombosis, common among some pregnant women who are at risk, or you've not had a stroke or any active liver disease, then you are a candidate who may benefit from hormone replacement therapy. So for those who have undergone hysterectomy, then you only take estrogen because you don't have a uterus. So you don't need the progesterone to protect you. So when we give you estrogen, this is for hormonal replacement therapy alone. for those who've undergone for hysterectomy. Now, the primary goal is to relieve hot flashes and, of course, other symptoms that come with menopause, because these symptoms actually respond very well to estrogen. And there's a lot of research that has been done on this. So if you're having mood disturbance, if you're having sleep disturbance, labile moods, some people who have joint pains and aches and pains, and even estrogen has been found to be very beneficial. And of course, so remember, with loss of bone density, the estrogen is kind of helping sort that out. All right. And you can take it either in oral or transdermal. Transdermal means you're putting it on like a patch, like an elastoplast on your arm. For those of you who have taken the Evra patch, that is a contraceptive method, it's the same thing. And they say this is transdermal compared to oral is better tolerated. What I find out to be that they are available in the Kenyan market. I know in the US and the UK they're there. So some people even bring their own or buy on Amazon and bring them here. So transdermal patches are better than using oral, because some people, they take estrogen orally, they're not able to tolerate it very well. But for those who can't, then it's okay if you take it. Then topical gels, you've had Premarin cream, estrogen creams and gels that you can put in your vagina, so that mucosa, that lining of the vagina, it's kind of, it's estrogenized, so that you're not struggling during sex. Others are vaginal rings. I haven't seen them in Kenya, and others are subcutaneous implants. Those I've not seen in the market either. So the choice of preparation, what you want to use, of course, the doctor will always discuss. One, of course, it depends on the availability of the drugs and then the cost, because some of them are more costly. So, for example, if you want to use the Evra patch, it's 1,800 bob a month. If you want to use the normal oral contraceptive, you can get it for as low as 100 shillings. So it depends on the patient's, budget. And remember, the problem with HRT, to insurance companies, those of you working in insurance, yani tuko na kesi na wewe, because this is a somewhat medical condition, but to them it's not a medical condition. So what happens is they don't pay for it, so which is really sad. So we'll send you to get the cheaper options, but we want there are better options that which are out there. So I'll not use the technical medical terms, but the better ones, like this one, which is called 17-beta estradiol. Why it's amazing? It's because it's a lower dose, and the estrogen itself is identical to the one we produce, compared to the old school one, which used to be in pills, called conjugated equine estrogens. So the identical ones, we have them in the market these days. They're lower dose and they're safe, so you don't have to worry about, oh, am I going to get this problem or get this problem. So anyone, of course, you've said, if you have high cholesterol levels, if you have active gallbladder disease and also liver disease, if you have particular blood disorders, the names are very difficult, then we may not give you estrogens. Then, of course, we've said that transdermal is preferred for women who have migraine headaches. So the people who migraines will become worse with menopause, and so they may benefit from HRT as well. All right. So therefore, if a patient prefers an oral preparation over a transdermal one, cost or personal preference, then we consider oral estrogen to be actually safe. Okay, for younger women, especially those who've undergone surgical removal or chemotherapy, radiotherapy, normally they will require a higher dose, because the menopause has not come gradually, or it has not come in a good fashion. So it's not come gradually. So what happens is they need higher doses of estrogen. It just maybe double the dose. So because and for those who get premature or menopause, the symptoms are much more harsher than those who are 45 and above, who are going through it gradually and naturally. Those who get it earlier, your ovaries were removed, or your ovaries were sort of, destroyed because of chemotherapy, radiotherapy, their symptoms are much worse. They have it rougher than other people, so they normally need higher doses of estrogen. And please, if it's menopause, don't just walk into our pharmacy, and Kenyan pharmaceutical industry is not regulated, and just say, I want estrogen. Please go to a doctor who will prescribe for you what is particularly given, and the proper formulation for people who are going through menopause. All right. So progesterones, we give women now. If you do have a uterus, then you must take progesterone together with estrogen. So the estrogen, of course, is to replace the lowering estrogen, and progesterone more so is to protect the uterus from getting, endometrial hyperplasia and cancer. So when if you have a uterus and I'm giving you estrogen all through, then the lining of the uterus thickens and thickens and thickens. That's called endometrial hyperplasia. So it puts you at risk of endometrial cancer. When we give you the progesterone, and you take it cyclically. So we'll tell you, start your estrogen on day 1, take your progesterone from day 12, and then up to this particular day. At the end of that progesterone, you're going to bleed, and that bleeding is actually protective. So even the girls who get polycystic ovarian syndrome, and they're not getting regular periods, we normally have to tell them, you need to bleed. You can't go a year without bleeding because we need to protect your uterus from that unopposed estrogen that's just happening. So if you do have a uterus, then your HRT will be estrogen and combined. If you've had a hysterectomy, then it's going to be estrogen alone. All right. So, and there are better estrogens in the market right now that are much more safer. You can take them orally, you can use them vaginally, you can also use them rectally. And let me tell you why the rectum is amazing, as much as some of you are going to cringe, is because of the number of blood vessels that are there. So anywhere where there's good blood supply, then the drug is taken in much better. All right. Then, of course, side effects of estrogen. Some people will complain of breast soreness. So if you find you're getting any side effects from estrogen, then you need to lower the dose of that estrogen, okay? If you're getting any bloating, even with progesterone therapy, they lower the dose, and then you can take even up to the lowest. Our hope is that you can tolerate, is that your symptoms are relieved by the lowest dose. Now, remember, I may give you a dose of estrogen progesterone, and you're still not getting better. And if you're not at risk, if there's no contraindication, I may increase the dose. But of course, there is also a cap. So those are technical issues you're going to discuss with your doctor in terms of dosing. All right. Other people will prefer to use vaginal or a route for taking progesterone, because some of the formulations, the tablet looks kind of big, and so makes some kind of comfortable swallowing. So you can just use it like you're putting in a tampon. For those of you who use pessaries for treating candidiasis or bacterial vaginosis, then you can use them vaginally, and they're safe, really, really safe. So what's the risk? So the Women Initiative study that was done in the US, so there was confusion in the data. So what people interpreted was like, for example, what I'm showing here is that 25% women, if you're taking HRT, you're going to get, you're going to get uterine cancer or breast cancer. And that was not it. So actually the study was stopped in 1 year. Remember, a lot of times when we're doing research is done over years. I'm saying, I'm giving you this and following you up for you to see what's going to happen. So it was stopped because of this misinformation. And so people who have been studying and doing a lot of work on menopause are saying, so the risk, for example, is 2.5. So what they found was like 2.5 women in 1,000. Now, in medical terms, imagine that's a very low risk, okay? So don't shtuka, it's actually a low risk. But remember, if already you're at risk, we're not going to give you these drugs already. So if you're at risk of getting heart attack, breast cancer particularly, make sure, in families, breast cancer is hereditary. Now, when we say hereditary, I mean, if your mother got it, you're going to get it. It means you might have the gene that puts you at risk. I think you all remember what happened to Angelina Jolie. Her grandmother had, I think it was breast ovarian cancer. Her mother had ovarian cancer. So she removed her ovaries. That's drastic. But because she found that she had the gene that puts her at risk of getting this, cancers. Now, when we say you're at risk, it means possibility, but doesn't mean you're going to get it. So when we say 2.5 in 1,000, all these figures I'm showing you here, actually in medicine, this means very, very low risk. So you really don't have to worry. So one thing is you have to think about when you're giving the HRT, you're not exceeding a period. So if it's better at less than 60 years. Above 60 years, usually we want not to give you, but by that time, hopefully the symptoms have kind of also relieved and gone down. We've talked about timolol, which also can be used for those who cannot take who are strict contraindication. Those who may have relative, may be allowed some estrogen, they can take tibolone, which kind of has properties that behave like estrogen, progesterone, and testosterone, and also protecting the bone. Then we've talked about Premarin cream for those who want to, you may not be having hot flashes, but you find you're having painful sex, so you're not lubricating. Then these topical creams, they're available and they are in the Kenyan market. They reduce pain during sex and they improve lubrication. Then, of course, lifestyle changes. I think we spoke about focusing on exercise, focusing more on strength training, weight-bearing exercises, yoga. You need to be agile. Remember, these bones are getting stiffer, so you want to be agile. A balanced diet, consult a nutritionist, and you don't have to omit food groups, okay? Include all food groups, including fats. Animal fats are even much more better for making cholesterol. All hormones are synthesized, or rather they are made from cholesterol. So imagine if you're omitting fats, and then you wonder, why am I going into menopause earlier? Why am I having other issues? Because you have omitted fat from your diet, yet it is necessary for the synthesis, the making of hormones. All right. Avoid processed foods. Okay. If you can take whole grain, which is amazing for your fiber. Remember, fiber also reduces your chances of getting colon cancer. And even HRT, hormone replacement therapy, was actually shown to reduce the incidences of colon cancer. Increase your fiber diet. Oh my goodness, please do not peel your mango and your apple. That skin is amazing for your gut, and you need that. Take probiotics. So if you go to the supermarket right now, you can find yogurts or kombucha, or what's the other thing called? Kefir. All these fermented things are amazing for your gut and also for your genitalia and your, especially your vaginal health. Even now, even without menopause. So if you find yourself getting frequent candidiasis, I tell people, I'm not giving you medication, especially if it's been recurrent. Can you just take some probiotic supplements, and they're there in the market? Or can you just start taking kombucha, start taking this every day, and you find you're actually getting better? Because candidiasis is one thing, it's difficult to treat. And we always say, as long as you're having sex, it's not something that you're going to HEPA. It's going to keep coming on and on. It's not an STD, so there's no one to go and shoot and all that. When I talked about dementia, about having, memory problems, one thing is read more, reduce your screen time. Oh my goodness, I'll need prayer requests for this one. And then engage yourself in things like Sudoku, crossword, engage your brain. Have your friends over if you can do couples night, or you can do your girlfriend's night. Play a game of Monopoly, play Scrabble, do all these board games, card games, get away from the TV. The more you engage your brain, the interesting about the brain, they say, is the more you engage your brain, is actually, it's like your brain forms new neurons, the connections, the cells, no, but the connections, it's better, and I see that with my dad. Very sharp brain, very sharp mind, because of reading more. And it doesn't matter what you read. And they say, even when you're alone, even read louder. All right. And then socialize more. One thing I think I decided this year is, if there's somebody I find myself chatting for more than 5 minutes and there's a story going on, let us get together and, let's take coffee. Let's just get out of that house, socialize more. I've talked about the fermented things. Fermented foods are amazing for your gut health. The gut means, when I talk about gut, I mean your intestines. All right. Vitamin C presentation. Now we talked about thinning hair, biotin. I noticed for me, my hair has been thinning. I don't think it's menopause. Sometimes I think it's just the heat, but biotin is amazing and even your brittle nails. For those of you like your nails, intermittent fasting, it may work for some, may not work for some. Just figure out what diet works for you. Do not go into a diet that you cannot sustain. If you're going to pick exercise that you can also sustain. Meditation and paced breathing, especially when you start getting these hot flashes, and you're struggling with memory, you're in the car, you don't know what you went to get in the supermarket, in the kitchen. Take a deep breath. Do yoga. I saw it's called, I don't know how to spell Pilates, so I wrote pilates, which is wrong. Anything that makes your body agile and more flexible. So you're not just doing cardio and strength training, you're also doing other stretching exercises. Okay. And I say one thing to motivate yourself is get a friend. There's a group called Fit Sisters, and I like when people write there, Niko Ruai, natafuta mtu wa kutembea naye, I live in Gong, I'm looking for a partner. So that person motivates you to get out of the house, because with menopause and perimenopause, you find yourself lagging. Waking up in the morning is difficult. Avoid triggers. Alcohol. It's not totally, you can't take alcohol, but if you take much of it, then you need to cut back on that, because it can trigger hot flashes. So other supplements that are there, these are hardly discussed with your gynecologist, because when we go to school, we're taught about promoting big pharma. But, I've been reading a lot, and it's amazing, and also watching a lot of YouTube videos and seeing what women are talking about supplements that are working for them. Now, remember, the thing about supplements is some may work for you and they may not work for somebody else. So it's just keep trying. Supplements are safe. You can keep trying until you figure out what works for you. So the old one that I remember, even from my mom and my aunties, was this. The second last one was even primrose oil. If you go to Healthy You, you go to Good Life, you're gonna see them. And then capsules, those ones are great. They help relieve hot flashes. Black cohosh. That's also a supplement I've seen in the market here. It helps you so it has estrogenic properties, and so you can use that to help relieve the hot flashes and night sweats. Vitamin D, I've talked about that. Then there's a supplement called 5-HTP. I've not seen it in Kenya, but it's in the US. For those of you who might be in the US, maca powder. I'm trying to remember who it is in Supermamas who sells maca powder. My goodness, this is, I think there have been such rave reviews about this. It's a natural product, so it's not something you're worried about. It's amazing for balancing hormones, improve your libido, and also treating hot flashes. Omega-3, we do not take enough omega-3. If you're going to supplement it in the form of a pill or the syrup, the one we take when we were kids, please do that, because remember, estrogen receptors in the brain, you're getting brain fog. You want to have good brain function. So omega-3 is great for that. Even for those who are starting pregnancy, we tell you take it because of the baby's brain. Sage also has calming properties, and I think it's an oil you apply around your neck, and it calms you. Remember, again, what may work for me may not work for somebody else. When it comes to soy and black cohosh, it has not been studied in patients who have breast and uterine cancer. So what happens is we just will advise you, if you've had the history of breast cancer or uterine cancer or ovarian cancer, then we'll tell you, please don't take soy or black cohosh because they have estrogenic properties. So there are other things you can take. You may take mannitol for sleep disorders, but then again, we also want you to also try and develop a cycle. Our bodies, for example, if you look at the thyroid hormone, cortisol is the feel-good hormone, oxytocin, these hormones, when you work out, they have a rhythm in the body. So if you're not getting very good sleep and you want to have what's called a rhythm in your body, you want to have a routine. I want to make sure I sleep by 10, wake up at 6. I want to make sure I sleep at midnight and wake up at 8. So make sure you're having a very good balance in terms of how you are balancing your life. You're not sleeping too late. There'll be a time whereby it's just not going to be good for you to sleep at 3 a.m. watching TV. It's just not going to be okay, because you're going to wake up and your brain fog is going to be worse. You're going to feel more crappy through the whole day. Seed cycling, people have spoken about seed cycling. I think one of the drawbacks about it is, oh my God, these seeds all of a sudden have become very expensive. And I think some of you know that. So day 1 to day 14, you take a tablespoon of flaxseed oil together with a tablespoon of pumpkin seeds. They say you can take them together, put them in your smoothie, put them in your oatmeal, put them in your food. Day 15 to day 28, which is the second phase of the menstrual cycle, you take sesame seeds. You can take the brown ones or the black ones. The black ones are much more expensive, or you can take sunflower seeds, and you can take them together. Then wild yam. So 2 countries that have very high fertility rate. Now, remember, the yam is related to the marker fruit. So I think I don't need to go any further. So wild yam, I do not know if yam is sold in Kenya. I remember a friend of mine trying to get pregnant and then later on menopause symptoms. And we're like, who is going to Nigeria? Because I've never seen yam in Kenya. Someone will tell us if it's available. And of course, as when things become, good for us, the supermarkets raise the prices. Magnesium is an important supplement because a lot of our hormones are, regulated by magnesium. So it's important that becomes a supplement, especially if you find yourself getting very laggy and behind. I've already spoken about these. Sorry for repeating. Then other important tests you need to do is cervical cancer screening. We've talked about this. For those of you who've never had cervical cancer screening and you're sexually active, oh my goodness, I will look for you and I don't give you a smacking. Please get screened. Maybe I shouldn't bring this up, but when you hear someone like Catherine Kasavuli, right now I have a 34-year-old, a 38-year-old patient. These are young women, young families with cervical cancer, and it's the only cancer we can prevent. Breast cancer you can't prevent. The purpose of getting a mammogram is making sure you catch it early. But cervical cancer, which kills faster and more, please get your cervical cancer screening. If you've never done it, please just let me know. I can tell you where to go. I have gone to Aga Khan in the month of October when they give discounts, and I get a nurse to do it. I've never gone to a fellow gynecologist to do a pap smear for me. Nurses can do it. If you're not able to afford Aga Khan, October is 1,000 when they cut prices. If you go to Kenyatta, 300. And it may take about 2 months to get your results, but you've done it. So please do not stop this until the age of 65 or 70, depending on the country you come from. Breast cancer screening, your mammogram, thyroid function test. It's good. Sometimes you find yourself getting very, you especially hyperthyroidism, whereby you can be losing weight, but you're not doing anything to lose the weight. So you need to worry about that. Or you're gaining weight and it's not really menopause. Or you're having just, you're just not feeling well. It's good to get this thyroid check, the thyroid function test checked. HbA1c, this one checks if you're diabetic. And then for those of you who've been pregnant, you know about the OGTT. If you've been to private hospitals, this is to rule out diabetes. Get your blood pressure checked when you go to your doctors. Of course, anytime, get your blood pressure checked. Stress test. So for those of you who've had hypertension or heart disease, then stress test where you put on a treadmill and they check how is your heart behaving when you're doing activity. So if you're doing minimal exercise, you're cleaning your house or cooking, you find yourself getting fatigued, you need to get checked. Colonoscopies for checking for colon cancer. And as I give this information, our mothers, those of us who are mothers of our lives, please make a date with them and go for this test together. And these days, hospitals have packages for these things. A pelvic ultrasound, especially when you have abnormal uterine bleeding, cholesterol levels, vitamin B and D12. Now, D and B12. So one thing that has been found with women is, especially when you find yourself getting unusual fatigue, you're like, why am I getting tired? You know, you're eating well, and you find yourself, so get your vitamin B12 and D checked, because it's important to get this supplemented. All right. So Susan Sommer is, she loves talking about menopause on YouTube. And she said it's a period whereby one is itchy, bitchy, sleepy, tired, bloated, forgetful, sweaty, and all dried up. It doesn't have to be this way. So there is hope for support, there's hope for supportive partners. And I hope that you have supportive partners that you can have open and candid conversations about menopause. And men can be so clueless as to what is going on, even you, because you're wondering what's going on, because nobody's talking to you. Nobody has told you what is going on. And so it's important that we get this conversation going. And so I just want to thank you guys for listening. That was long, about an hour. I'm sorry about that. So I want to invite questions. And I think, I don't know if there are any on the chat, Christine. Maybe you read those, and then those, I do prefer that you ask. And it's I would love to see your face if you can unmute, and then we can see you.
That sounds splendid,
Great.
Dr. Harry. That was wonderful. Thank you so much. Very, very insightful. By the way, it did not feel like it was, it didn't feel like it was 1 hour, which is actually, we've done it for an hour. So just back to instructions, I see Naliaka has raised her hand, but before we get to Naliaka, I'll ask the questions which have been put on the chat. I'll start with one from 33 Susan.
Questions.
Wait, there's one from, let me see, there's one from Susan, and Susan's,
it's okay.
Susan's question is, it's on the chat, you can also see it. I hope you can just give me a minute.
I think for me, read the questions, then for me it's easier to answer than going and seeing, because I start getting confused, I guess.
No problem.
I don't know if that's cool.
That's very, very
those
possible.
Those that have been repeated, you can just mention they've been repeated, or maybe some people sometimes ask a question which I'll answer at the end.
No problem.
So I'm so sorry, Lydia. Lydia.
It's okay.
Information overload. I'm so sorry.
It's okay. I'll start with the first one. The first one is from Susan Kabuku. Susan says she is 40 and has fibroids 8 centimeters big. OBGYN has suggested hysterectomy. Is this her best option? She says, I have had fibroids removed once before. So that's the first question. And then we'll move on to Patricia, and then we shall take it up from there.
All right. Okay, so for Susan, okay, I know fibroids are not the discussion, but fibroids are so common, so it's okay if they come up to date. So that's fine. That's what I'm saying. Some questions I'll have to ask you personal questions. I don't know if so hysterectomy one, the decision for hysterectomy one is either whether you're done having children or not. So is an 8 centimeter fibroid big? Yes, it is big. It's the same size as the uterus, and especially if it's asymptomatic. I have a friend of mine, she's 47. She has a fibroid which is about this big, it's big. But because it doesn't give her problems, Amesema, because I keep asking her, but she tells me, when I die, come to the mortuary and remove it. Best friends are crazy. So 8 centimeters is big. If it's giving you symptoms, hysterectomy will be done because you're done having kids. The first time they were removed only fibroids was probably because you're not done having children. So you may get that done. The other option is getting some monthly injections. You've gone through surgery before, so I can totally understand why you'd be averse to going through surgery again. So for me, when we give patients options, especially when you're done having children, it's actually easier for the gynecologist to make a choice for you. But any medical doctor should give you the options, and then you make what is called informed decision. So I'm like, okay, yeah. And then if that doesn't work, what do we do? If this doesn't work, what do we do? So when it comes to fibroid treatments, definitive, of course, if you don't want to get fibroids again, is remove the uterus. So if you're done having kids and you're thinking, I don't want this problem again, then you can remove the uterus. Now, remember, your ovaries need to be left behind. So there's no doctor should be going and saying that you're done. No, your ovaries should be left behind. So I've had patients who had hysterectomy and ovaries were removed without their consent. That was so wrong. Unless there is unless there is a contradiction where you need to get your ovaries removed. So that shouldn't be done. So your ovaries are important then to be there. The other thing you can do is due to an artery embolization, whereby you don't have any uterine surgery. They block the vessels that feed the fibroid. And then it just shrinks and shrinks and shrinks and shrinks. So this also makes sure you don't want any more children. I think some doctors don't do it if you want to have any more children. And it's a great, amazing way. If you don't want to go for surgery, it's amazing. The only catch, and if you work for insurance, I have got beef with you because they don't pay for it. It's expensive, but it's an amazing therapy because you don't have to go for a surgery. Then the other one, it's done in the morning, you go home, and then it shrinks on its own. Then the other one is whereby you get some drugs that block the ovaries. We're not removing the ovaries, we're blocking the hormones. And so that uterus is going to shrink and shrink. The only problem, of course, if you're blocking the ovaries, then you're going to have menopausal symptoms. So what we do sometimes is we say, let's shrink it and then let's give you something to counter the menopausal symptoms. I think, Christine, I'll share my number so that in case of anything, you can call me. If I don't pick up, please forgive me. Just send me a message on WhatsApp and I'll get back to you. I'll actually call you back because I think some things require a longer conversation other than asking you personal questions here. Yeah.
All right, thank you, Daktari. I'm sure you'll share your contacts and then whoever wants to connect with you, that will be absolutely great. I see time is really rushing. I will move to the next person so we can give as many people as possible an opportunity. There's one from Patricia. Patricia says, can you use HRT when you're taking anticoagulants? That's her question.
All right, just let me type my number and
okay.
Okay, just 1 second. So what are you taking the anticoagulants for? So remember, if you've had an issue with clots, so you're taking anticoagulation, is probably because you've had an issue with clots, either deep vein thrombosis, pulmonary embolism. So HRT is going to be contraindicated. No doctor is going to give you estrogen when you're taking anticoagulants for deep vein thrombosis. So deep vein thrombosis, some of you have experienced it, whereby, and comes in pregnancy or not, majority in pregnancy, is you get a clot and your leg. So what happens, you just find one leg is swelling and it is hot. So whenever you see that happening, please run to the hospital. That's a clot. It could be a clot, especially one side of the leg. So if you're taking anticoagulants because of DVT, anything to do with clot, you will not be given estrogen. So you may have to consider the natural methods. The other thing is, I was just listening to a video, and this lady was saying for her, she had breast cancer. Actually, she was when she hit hot flashes, became crazy. She was put on antidepressants like gabapentin, other drugs like that have other uses, but have helping with like oxybutynin. They helped with with hot flashes. So there is a solution. It's not like you're going to struggle. There are other alternatives. You can't take hormonal therapy. Yeah. You're muted, Christine.
Oh, sorry.
You muted, Christine.
I'm here now. The next question is from Kongere. Kongere asks, does menopause cause bone loss?
Yes, I talked about that. She might have joined late. It does. So estrogen is an amazing hormone. Oh my God, it comes in puberty and then we're kind of pissed off with it. Then menopause, and then we're happy with it because it makes us really happy and we want to have sex and feel very sexy. Then menopause comes and you're like, oh crap, because it's such an important hormone. So it regulates so many functions in our bodies, and it stabilizes cholesterol. So if your cholesterol starts going up, so even for bones, when your estrogen goes lower, what happens is there's more bone resorption, meaning the bone is being eaten and less is being built. So what happens? There's an imbalance. The bones start thinning. So the remedies we talked about, first let's start with vitamin D, vitamin C supplementation, strength training. Now, I think those of us who are on Fit Sisters, I know some of you are on Fit Sisters, those of us who follow Evelyn, Christina, who are workout fanatics, they say with menopause, your estrogen level already is going down. Your testosterone level is going down. Please do not be worried about lifting weights at utakaka mama naume. You will not reach there. And especially in menopause, you're not going to get that buff, okay? So And even you've seen with, I think she's called Evelyn, you guys know Evelyn, the bodybuilder. She still has a feminine side, and for her, it's competitive. That's different. So yes, you are likely to lose bone mass. And also, I said one other reason for losing bone mass is going on a crazy diet and losing crazy amount of weight and doing too much cardio. So make sure you're building your bones. Your balanced diet, you're getting about 1,200 grams and 8 of calcium, 800 milligrams of vitamin D into your system every day. If you can't get it through your diet, then make sure you can take supplements. Of course, the downside with supplements in Kenya, oh my God, they're so expensive. I know people who send for them abroad because majority actually, imported. So hello, business people, there's an idea. It's important. So estrogen, yes, causes loss of bone mass density, but there are ways of trying to slow that down. You can't stop it, but you can kind of slow it down.
Thank you, Doc. There's another one, just a quick rundown on ways to minimize hot flashes, just a few points on how we can minimize hot flashes. I know you mentioned about buying fans, keeping our windows open and being subjected to all the mosquitoes in the world. Is there anything else?
So of course, hot flashes. So one, if there's no contraindication for taking hormone replacement therapy, it goes a long way. And of course, I talked about better. With time and advancement in medicine, there are better formulations of all this medication. They're not the old school ones where the estrogen dose was very high, and then you start getting symptoms like sore breasts and other things. The formulations are much better. They are more identical to the one we produce ourselves, and they're safer. So you start with a very low dose. And remember, please do not go buying yourself. You need to go and see a doctor for this. So, and it's unfortunate that menopause we were taught the topic, but it needs to become a specialization. We need people who are specialized in menopause, because this is going to actually make sure you get you get the proper knowledge. So HRT can help with hot flashes, and that one is proven. The other ones, of course, I talked about opening the doors, the fans and everything, but that may not work for you. You may be there with an AC top range Philips and you're still burning up. Or you are, you're not at home, you're in a place where there's a meeting and your hot flash is coming. So HRT can work. The other thing we see that can work can be taking, those who cannot take HRT can take medications like antidepressants. There are specific ones. There's gabapentin. If I talk about the medical names, they're just going to confuse you. So they're antidepressants, antiepileptic drugs. So these drugs were formulated for, let's say, depression, or they were formulated for epilepsy. But then as people took them, they're like, okay, how come this is not happening? So drugs are made for a particular reason. Then people discover, oh, wait, they can actually do this as well. So those are other drugs, especially for those who can't take hormonal therapy, that can help with hot flashes. And this is research that is proven that they work great and, with minimal side effects, because drugs are coming to the market, they're making better formulations. So yes, hot flashes, when we talked about the natural methods, are things like black cohosh, maca powder. We talked about yam, taking wild yam supplements. I saw someone talking about I don't know about the supplements that in the market for menopause. There's Menopause. There are quite a number in the market, so you can try them out. They have vitamins and minerals that kind of help balancing all this out. Yeah, but hot flashes, if they are debilitating to a point whereby your quality of life is affected, don't get surprised if you're given HRT, and don't be afraid of it. And then you tap at the dose, and then you can say, let me try something else like a supplement or a natural remedy. And if that works for you, you continue. Some people do HRT like this. It's not continuous. So you start, you stop. I'm getting better, then you stop. But a lot of times I think they advise take it for a while. But beyond the age of 60, maybe, by that time, the menopause symptoms have stopped. Yeah.
Okay, thank you, Doc. Moving on to the next one. We have one here from Patricia. Patricia says, after hysterectomy and the ovaries were left, can you go for a pap smear after hysterectomy?
No, so remember the cervix. So when you have your uterus, it looks like this. All of you can see me. Like this, then you have the cervix. It's like a pear-shaped. When we do hysterectomy, hoping that the doctor did a total hysterectomy, meaning the entire uterus was removed, the cervix also was removed, because the cervix is part of the uterus, okay? So when we talk about the uterus, it's like this. It's like a pear-shaped. The lower thin part, you're like, oh crap, that's the cervix we're checking. That's the part that opens so that the baby can come out. So that's part of the uterus. So when you've had a hysterectomy, that part has been removed. And before a hysterectomy is done, you must have a pap smear to rule out you don't have any cervical abnormality. Then you remove the uterus and there's cancer. So if you had a hysterectomy, then you probably had a pap smear before the hysterectomy, and no, you don't need any more pap smears. Your cervix was removed. Now, if you had a subtotal, meaning partly removed, then you have to continue the pap smears.
Okay, moving on to the next one. Catherine, she says, her name is Kathy, she's 37. She says, I saw a gyna last year as a result of bleeding between my cycles. So got some tests. They realized my estrogen levels were slightly high and normal, and I'm not pregnant. I don't ovulate, and I also get hot flashes, low libido. What do I do?
So of course, the first thing I'll ask is on contraception. Issue on contraception. And then estrogen levels. Now, remember, if you go and get what is called a hormonal profile, they're very expensive, sometimes very unnecessary. We know how to make money, so I'm sorry about that. So hormonal profiles. So when I send you for hormonal profile, I want to see estrogen level, I want to see progesterone level, I want to see prolactin. There's a whole bunch of, and they're very expensive. And sometimes they're done unnecessarily. So if you come to me at 45, 47, 48, 50, and you tell me I will not bother with hormonal profile. I'll say, this is probably what is happening. So what I would want to know is, are you on contraception? Because contraception can actually mess up your cycle, but not mess it up. You also want the contraception. It will just distort. Either you don't get periods at all, or you get irregular periods. So if you're on contraception, then maybe you might have to stop it, or you may have to regulate with pills and then see what's going on later. Now, estrogen, if they say it's high, it's very rare to find high estrogen levels. It's quite rare, unless, and also they need to look at, when we measure it, they normally mention which day of the cycle did you take the estrogen, because there's some days it's higher, other days it's low. So if they just take one ballpark figure, it could be on the wrong date. So maybe I've put my number there. You can email me your results, and I can see them. Then I can not email, WhatsApp me your results, and I can call you. Then I tell you if it's anything to worry about or not. Yeah.
Hey, Dr. You ended up sending me your number by inbox. If you can find a way to send to everyone, just put it in the chat box. It came to me.
God. How do I? Oh, it has.
You say to everyone.
Make up for everyone. Okay.
No problem. So moving on to the next question, I see we still have a bit of time. I'll ask one from Joy. Her question is, what can one take as an energy booster during her periods? She's 32, but she feels she's going through early menopause, and then worst is low energy levels during her periods. I'm sure your tips on that will help a lot of us.
Yeah. Oh God, that is so common. Please, if I don't have an answer to something, please don't be surprised, because we don't have an answer to everything. So remember, in the menstrual cycle, there's that part. So after you ovulate, the egg comes out. Now, if it is fertilized, that is within, it kind of hangs out there for 48 hours. If there's no fellow there, then it just, it will just hang around, and then it goes. If by day 21, the body's like, she's not conceived, so what will happen is progesterone will go down. And that's when people start getting these PMS symptoms, the bloating, the just the fatigue and everything. So one thing I always say is, of course, the natural remedies are, I would say, first of all, just make sure you're having a good diet, you're eating healthy. Maybe check your vitamin D, vitamin B12 levels. But sometimes, I won't lie to you, majority of patients we've said, let's test these patients, we found nothing. Really, we found everything was normal and attributed to, to just normal PMS. So sometimes, things like supplements. So I think vitamin D has been shown for some people to help. Others, they say magnesium. Others, just even getting out and getting active, making your body active, making sure you're eating healthy. But for majority, I will not lie to you, it's just going to be called like just premenstrual syndrome or symptoms, and really nothing much can be done about it, because it's part of the nature of your menstrual cycle. So some things, without us pumping you with medication and even supplements, I think just get your diet in order, get your activity in order. Just make sure you're getting out there, you're exercising. Some people have to work out harder during periods, because I see people asking, can I work out during my periods? I'm like, in fact, harder, because really it does. You feel your energy levels are low. So If it's something that is really constant, then maybe you may need to see a doctor and maybe a nutritionist, or even an endocrinologist. So those are very different from, we do work with them in terms of, they tell us, this is what is going on, but majority of them, we refer to endocrinologists if we can't find a reason what's going on. Then they can do some testing for some hormones that they know what to look for, and then they can guide you. So things like thyroid hormone, things that we said, vitamin B12, vitamin D deficiency, those things can be checked for, just to make sure you're not having any deficiencies, and just make sure you're eating a healthy diet. I think that's, and getting out there and working out. Yeah, it's hard. It's not easy. Oh God, it's not easy to work out. Oh God, no.
We hear you, Doc. Thank you for that. Moving on to the next question. This one is by Caroline. She did mention if you can empower us a bit on something called andropause for men. I've never heard of that.
Oh. Well, I've had of a 90-year-old guy, knocking up a woman. So andropause, God, I should have read about it. It varies with men, I don't know, but I think a lot of it also is related to lifestyle. And like us guys, whether you're healthy or not, you're going to go through menopause, whether you are fit as I don't even know what to call it, you are going, but for men, it really varies. All right. So if you've had a prostate, your prostate removed, some men, of course, struggle with erectile dysfunction. And we're seeing men as early as 30 with ED. So you can't say that's andropause. And for them, it's not like their testosterone levels really dip like the way our estrogen levels go. So andropause really varies with men. It's not really known when it occurs because it varies with men, with ethnicity, with different communities. But it's not really known. But I mean, if 90 years old, a guy can give a woman a child, then it means it's really not, there's no ballpark figure. Like we say for women, 51 is around the area you're going to get menopause. So for men, it's not really known. But yes, there have been reported cases of andropause. Some people just say it's low libido, low energy. Others, they may have had surgery. If you have testicular cancer, of course, they're going to remove your testes to protect you and in its life. Then, of course, you're going to go through andropause. Other issues of ED is more, I think, a lot of them, it's lifestyle, diabetes, hypertension. So just make sure, so your men, if you're taking care of yourself, just make sure these guys are also eating well and eating healthy. Get them out there. Don't be like, babe, dogs, you get out together and go and do some activity together. Yeah. So andropause, I won't tell you much about it, but maybe one day I'll probably just post something about it, but I wouldn't say I know much about it.
Asante, Doctor. Moving on to the next question. Lucia, most likely I know all the way from Mombasa. She asks, after TL, do you still get the hormones produced as usual? Is it BTL or
Yes.
TL? Is
Yes,
BTL different from
So,
TL? Yeah.
No, they're the same thing. Just B means it was done both sides, bilateral. So TL is just a short form, but bilateral. So for those who have had BTL, and I think BTL is, so that this is we call it the permanent contraception. We've tied your tubes, we've cut them, sometimes we burnt them. So when I was doing internship, I remember I did a BTL for a patient, and then she got pregnant. So I was like, this thing didn't work, So whenever you go to your doctor, even with the BTL, I think when you sign the consent form, they always tell you there's no guarantee that you can't get pregnant unless we remove the tube. So when this patient told me, wait, I'm pregnant, and if I was in China, I might have to support her child, according to those laws. But the way BTL is done, if it's done the proper way, now if someone does it the wrong way, whereby they clip the vessels that are near the ovary, then you may actually go into menopause earlier. Why? The blood supply has been cut off. So there are other small vessels that will feed the ovary, but eventually they're gonna, keep quiet. So there's a particular way when we do the BTL, even when we lift up the tube. So what I do is I lift up the tube and I make sure I cannot see any blood vessels. And so so you have the ovary here, then you have the tubes like that, then you have the uterus here. So there's an area here where we normally bend the tube like that, then we tie and then we cut. But we have to make sure this area here, there's no vessel that we're gonna clip that may be supplying blood to the ovary. So there have been a few cases whereby, BTL was done and women went into menopause. And I think what has been suggested is possibly that the way it was done was the blood vessels that are supposed to be also helping the ovary get blood supply were clipped or nicked. So ideally there's a proper way of doing it, but if it was done properly, and I think if you had a qualified gynecologist doing it, because this is Kenya, then I highly doubt you're going to early menopause. And if you do, maybe it might not be necessarily to the BTL, it might just be just it happened. But ideally, no. You know, my mom had a BTL, her sisters had a BTL, and one went into menopause at 52. My mom went to menopause at 48, which was normal. Yeah.
Wow, that's good to know. Moving on to the next question. No, just go back to that. I'm just thinking some of these questions we need to be aware so that by the time we are thinking about going for a BTL, then you can ask, well, how is the procedure like? You have that kind of information, and then you can be able to, you know, just have it it done properly. So of course, you can't see what they're doing, but it's important for you to ask and get assurance. Yeah. So moving on to the next question. Looks like somebody wants us to come for a baby shower. Naliaka is asking, can a perimenopausal lady become pregnant? Somebody has hopes and wishes this year for us to come for a baby shower.
Oh my God, so yes, you can. Remember, my God, I have had women shattered at pregnancy after 45. And I'm like, okay, were you using contraception? You know me, I was told, oh, Aki, please don't listen to your friends. Come to us, we help you. I had a client at 48. Oh my God, I think this was the most devastating story. The husband comes and tells me, hey, madam, you know, when someone calls you madam, you know, doctor, just know it's not going to go down. This consultation is just going and he told me, he said, they could get this baby out. This is not the retirement I wanted. And he went on and went on. The wife is just quiet. So I told him, you know what? I asked the wife, do you want to talk when he's here? So when you're 18 and above, yes, you can decide, you know, it's me and the doctor, but it's good when your spouse is there. Eventually she carried her baby, but yes, she was 48 and had gone 6 months without a period. So she thought, I've reached menopause. Remember, it's 12 months. 12 months tumesema umefika kabisa. But 6 months, 48, she was pregnant. So perimenopausal, yes, there's a possibility that you can get pregnant. So we normally say, please use your contraception until we diagnose that you have menopause. Please, please, please. You know, but then babies are blessings, you know, when we know and have friends who you know, not able to have children, then for me, every baby, such a blessing, such a joy. So it's amazing. She went ahead and got the baby, but she told me, I'm not living here without you removing, not even tying, remove my tubes. And I had to go back to the word and show her, they're easy, you know. But of course, we leave, remember when we do a BTL, we're just cutting the tube and tying and cutting it. We are not removing your ovaries. We leave them there because you need them. Yeah.
All right. Thank you, Daktari.
Please don't play around with this body.
You can say that again. I can imagine. Oh my gosh, being at is it called antenatal or postnatal? Which one is antenatal at 48? What?
And that lady, remember, she says, sasa nitakuwa nakuja hapa na kapa na ma 20, 30-year-olds. Aki Kakuti tu nipatie consultation yangu mimi na wewe. So I had to reschedule her clinic in another ward, a different clinic. So I see her. So because you could tell she's a bit older. And she said, I cannot sit there with 20 something. And they're like, now wewe, kwani watoshika na you know.
But you never know. You never know. Everybody has their story. And like you say, you can get your first baby at 49, and that's God's blessing to you, and it's just okay.
Absolutely, absolutely, yeah.
All right. I see we're almost running out of time. It would be nice to hear a couple of voices. I see we don't have a lot of questions in the chat section at the moment. I know people want to unmute and ask, but I'll just start with Esther Mbao. I know, Esther, this is something you've mentioned over and over and over. If you can unmute, and for anybody who's asking a question, I'll ask you to be brief so we can give as much opportunity to as many women as possible. Esther, libido away. Are you there?
You just had to put me on the spot.
Go ahead.
Anyway, I just needed the doctor to normalize the crazy libido I'm currently experiencing. To be very honest, I think I even said in the chat that days I even just get mad at the floor being the floor, and I know I'm ovulating. So yeah. Maybe she can just touch a bit about that. Is that normal? Yeah. And I'm not on any family planning, by the way. I'm on BTL. Let me just first normalize that.
So one, congratulations. Oh God. I'm sure there were women who are like, she's got a good libido. I think that's great. And there's nothing to reduce it. I'm sorry. And there's nothing wrong with you. Remember that. There's nothing wrong with you. So some women, and I think, I don't know if this was research or just, I think, hearsay, but when you've done a BTL and you're sure I can't get kids, there's almost a, whew, and your body is, I don't know how, I'm not going to ask your age here, but I think there's a relaxation of, I'm not worried about kids. I'm not on contraception which can mess my libido. There's a place I've reached. My kids are grown up. There's also just a mood you have that raises your libido. It's not like necessarily you're there looking for sex. No, it's just a mood. Because remember, sometimes even our own, sorry for the word, Christine, horniness is not really something that you can say at your feel. I don't know how to describe it. You just have it without even having the need to have sex. And there's nothing wrong with that. So for me, we're not going to give you anything to lower your libido. And there's nothing wrong with it. I think it's great. It could be just a stage in life that you're going through. You're relaxed. Your kids are in school. You have got time with your partner. You've got time, the pursuits you have. And I think just that good mood would give you a good libido. Remember someone who's depressed and going through a rough time, that libido goes down because of this chemical functions. They don't have any feel-good hormones in their body. So I think for me, it's great. It's great. And I think you should celebrate it. So nothing is wrong with you, Esther. Nothing.
Thank you very much, Dr.
Pounce on that man right now.
Yeah, perhaps what she just needs to do is to get it sorted, right? Because
I think so. But I've met women whose libido in pregnancy is insane, and the husband comes and says there's a problem. I'm like, okay, what's the problem? And that team tells me, Kakuti takulipa. I'm like, lipa your 3K. And he tells me, akibana usiku naamshwa unaumama, and she's pregnant. And then another woman comes and the libido, she's pregnant and the libido is off. So I've come to appreciate women are diverse and special. When it goes low, of course, we are worried that if you have a normal and higher libido. And so, and this woman, when she's not pregnant, the husband is like, okay, it's begging. But when she's pregnant, she's there at night, 3 a.m. And now he was getting very tired because now he would go for meetings and fall asleep because she particularly wanted to have sex at exactly 4 a.m. And this is the time like his sleep checks in. So there's nothing wrong with you, Esther, nothing. And don't try to say at you, I'll take something to reduce the libido. I think that's great.
Well, thank you very much, Dr. I wanted to ask Arisa Wanjiro to say something about low libido, but I think she was just chiming in the chat section because perhaps there are women here when it comes to menopause and all, low libido could be an issue. So the opposite of course, having a very high libido. Perhaps you can address that as I move towards to Marcella. Lillian, get ready to ask a question. And Grace Maina, I'm not sure you've picked out your question. So we'll start with low libido, and then somebody's libido has also gone on holiday, and sisters, and then we can take it from there. Dr. Over to you.
Yeah, so I think in this with the low libido, you need to investigate why that's happening. Are you on taking contraception? Are you on any other type of medication? Think about your weight, think about your diet. Some things are actually much more natural and to a fault, our own fault because we're not taking care of ourselves. And something about women, we have to be now, unlike menopause, which is a natural, you can't modify it. It's gonna come, it's gonna come. But when we say there are modifications to our lifestyles we can make to make things better, I think we need to just own that ourselves. So if libido is low, for me, that needs to be investigated because remember, even as a doctor, it's very wrong for me to manage you medically and not think about the fact that you're in a relationship. My mom told me, as long as people are having sex, y'all gonna make money. Great. And I'm touched, so that's great, So if it, anything that's going to affect your well-being, and remember that includes your social well-being, your emotional well-being, your mental well-being. There's somebody you're with, you have a partner, and you don't want to be in a place where you're denying them this pleasure, then remember, anything that's affecting your libido, you're not yet menopausal, you're not even perimenopausal, then get it checked. Go to a doctor and ask them what's going on. Some things, you might say, dude, you just need to up your game, because also if it's not putting out, then you're thinking, I'm not in the mood as well. There are women who don't care. Like, I think I watched I don't know who I think there were some two chicks on Facebook, and someone was saying, Yeah, I never. She like, she don't care for foreplay. I did this ling 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 ling. I did. She, dude, and that's what she likes. Then her friend, this Murugi, someone I think, and her friend is like, me, I need to be, I need to be, I need to be. Her, she's like, me, it's in your time. If the guy that in the kitchen, if I'm given one good, 10-minute shot, don't start bugging me at you. So women are very different, but anything affecting any other sphere of your life, that accounts for health. So when we define health, we're saying your wellness physically, socially, economically, that includes financially, mentally, spiritually, and emotionally. Anything. And remember, sex encompasses all these areas. Annoying, if you have ulcers, it's just you and your stomach, but sex, there's other people involved. If your relationship is not doing well because this is being affected, then again your kids get affected. So unlike Esther Mbao, she ain't gotta see nobody. Where your libido has been affected, you are not in menopause. And even if you're in menopause and you're perimenopausal, remember we've talked about HRT, you may need to start it early, and there's nothing wrong. We've debunked the myth that if you're perimenopausal, yes, you can take HRT if your symptoms are just out of this world. It's affecting your quality of life. Yeah.
Thank you very much, Doc. We'll quickly move on to Lillian Marcella. If you can unmute and quickly ask your question, then we can then move on to Grace Minor, then Lindsay.
Hey. Good evening. How are you all?
Good evening.
Hi, Marcella. How are you?
I'm fine, thank you. Now, at my age, I've never used any contraceptives. I'm just worried if I'm normal or something. I don't know, but I've never loved. I'm 39 years old. I have 4 children.
Sorry. So you're 39. You've not used contraception. What's the issue?
I've never used, and I don't like. I don't know if it has any implications with me.
Hello.
Hello.
So you're 39. You've got kids. You've never used contraception.
Yes, I've never used.
So what's the question? What's the issue?
Is that normal?
Yeah. Oh yeah, that's fine. In fact, that's great. But again, I guess my question is, how are you able to control when you want to have a baby? Or for you, safe days works? Or how are you able to control that you don't have a baby?
Yes, my hubby is a doctor and we do safe days.
He's got the calendar. So there's nothing wrong. Yes, if you do have a regular cycle, yes, safe days can work for you. It means you know how to count the days. That's a whole other topic because that's going to go off topic. So that is fine. You don't have to have ever used contraception. There's nothing wrong with you at all. And it will not affect. So when you use contraception versus who use contraception, if we take two identical twin sisters, give one contraception, another one we don't give contraception, it will not affect when we're at menopause before the other one, or it doesn't affect that. There's no effect. So menopause is typically your own body that's going to decide when you're going to go into menopause, when your eggs are depleted. Yeah. So not really.
Thank you.
So even with well, I think the only one I've heard about is if you've been taking the pills or some form of contraception that prevents ovulation, which is most of them, then it may delay a bit because you're like keeping some eggs. But again, I think what I've heard is that they don't stay either. I don't know. So there's a lot of confusion about that. But if you've never used contraception and you're able to use the safe days, that's fantastic. Because I think we know a lot of people do struggle. I don't want a baby, but I have to use contraception. I don't have a regular cycle. I don't want to oops a baby and I'm not ready for that baby. So for you, if it's working, if you've never taken, oh my God, you're the luckiest woman. You're lucky. I mean that you have a good cycle that you can you can know this day and this day, baby, no, I'm a bag love, I'm a yeah. So you're good. Oh my God, you're good. Oh my God, you and Estambao are like healthy women, champions.
Thanks a lot. And this one
No,
actually,
I'm sure many are. It's just that you guys have talked about it. I think that's great. That's great. You're good.
Thank you.
Yeah, there's no added benefit of health because you're taking contraception. No. There's been things that it prevents. It may reduce your risk of cervical cancer. Others said no. There's just no, whether you take it or not. It's for a particular preference. Yeah.
Wonderful. Lillian, you sound like you've been responded to. You should be good now. We have 10 minutes to go. Grace Minor, I'm not sure if your hand is still up or your question was answered. Grace?
Hi, it is.
Go ahead.
Good evening. I decided to just be patient and wait.
Good evening.
Hi, Grace.
Hi. This is really enlightening, by the way. It's funny how little we know about what we should know. But I think for me, when you talked about perimenopause and brain fog and memory, for me, I think it's almost an aha moment. As we speak, I'm 45. I am currently seeing a therapist because of memory issues. I have been to see a doctor. I'm currently on omega and thiamine, B1.
That's great. That's great.
But no one ever linked it to menopause.
To perimenopause,
Never
yeah.
crossed and it never crossed my mind because it's actually crippling. Within the last 2 years, I even thought maybe it's COVID that threw my brain off. It's bad. I go to places and I find people talking and they're talking about a function I was at. No recollection whatsoever. You know, half the time you're not too sure, okay, have I been to this place? You know, I've been once, I have no recollection. And it took me a while to figure it out, to realize that something was off.
Is there anyone in your family who has dementia or Alzheimer's?
As far as I know, no. So for me, this was a starting point. You know, this is the investigative process that has begun to try and figure out what's going on.
Yeah.
You know, but even hearing that it may be linked to perimenopause opens out another, you know, another facet. You know, I mean, for me, I just wanted to ask how bad, when you're talking about brain fog and memory issues, how bad are you talking about?
So it varies, but it can get really bad. I've had an auntie of mine, like really bad. She will leave the house and reach the supermarket and not remember why she went to the supermarket. Or she will go to the kitchen and totally forget she was cooking food. And the next thing you know, it's burning. And we thought this is dementia, this is what, but and then I think she's got a son in the States, and they went and did evaluation for dementia and Alzheimer's, and they said no. They said, how old are you? And they said, oh, she was like 47. And they're like, it could be menopause. And so what she started doing, and I think she's always really been having these conversations with my dad about engaging your brain. So what I think, if there's any medical person here, they can correct me, and I think I'll correct myself if I'm wrong, is they say when you engage your brain. Now, trust me, when we were younger, and I'm sure all of us here can testify, there's a lady on Supermamas. I love her psych for reading. Oh my God, she keeps asking for books, and I'm like, the one I bought in January, I haven't read. Like, I think she's an ardent reader. I think, Christine, you know her. Whenever, she's just amazing. You need to engage your brain. I think what has been shown is that whenever you engage your brain in anything that teases your brain to think more, then you're actually forming new connections in your brain, which is so important as we age. I was talking about my dad. My dad reads aloud because he's done a lot of reading and a lot of research. He's always just checking on, because he's got friends who've gotten dementia, who when he reached home, like one of my mom's friends was like, oh, my dad is saying, I've reached home. And she's like, oh, from where? And my dad's like, okay, 10 minutes I was at your house, and just forgetfulness and memory impairment. And so some of the things that have been suggested also is I think taking a tablespoon of coconut oil every day. Remember, fats are good for you. But remember, it's not Elianto, it's not Safi, it's not Rina. It's literally healthy fats. So they say good fats are for your brain are coconut oil, avocado oil. And if you can't take them like this, just put them in your food. I make my rice, and if I want it to come out to one because I make terrible rice, I put coconut oil. Fats are good for your brain. I said, do not omit fats from your diet in the name of I'm losing weight. Fats actually have no effect on they say actually they have no effect on if you're doing intermittent fasting or doing fat loss lab, those kind of drastic diets. Fat, they actually tell you to take fat. You can take cheese, you can take butter. But one thing is engaging your brain. You want to keep forming those new brain connections. So you're not going to form new cells. You're just going to form new brain connections. So one thing is engaging yourself in reading more and reading aloud. If you can go somewhere and sit, oh God, Nairobi these days is amazing place. You can just go and chill and sit and read a book. I'm upstairs. If my door is open, I can hear my dad reading. And he's 85 and he remembers the first date with my mom. And I'm like, dude, his friends don't remember Jack. But he's so scared of dementia that he's doing everything possible. He does Sudoku every day. Crossword. I posted that on Facebook. Those who also my post. I cannot do those crosswords. He'll tell me, go buy your newspaper. And I realize he's engaging his brain, trying to think. Oh, like sometimes he'll ask me, what word is this? He's engaging his brain. So try those just simple natural methods. Continue with therapy. Oh my God, I used to think therapy is for crazy people. Continue with therapy. But I think importantly, let's start with what is simple. Engage your brain. Go out. If you have a friend you find you're chatting, I learned this. If you're chatting for more than 10 minutes on WhatsApp, please go out and take off with that person. Stop wasting your time on the phone. Just Christine, tuendelee na story kwa kahawa. It's this, and remember, the older we grow, and especially if you lose a spouse, like my dad did, he became a bit antisocial. And women become also antisocial. It's like you're afraid of meeting your friends who ask you, how are you? You don't want a pity party, And so it's important to go out there and interact with people one-on-one. So as long as you're doing stuff to make sure your brain is doing ding, 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 and it's not the television and it's not your phone, unfortunately, some things you have to take the bull by the horns and say, okay, I'm going to start doing this. And there's a guy, I think, who's talking about Elon Musk, and I think people like Jobs. Start with something like just a chapter of a book. Start with whatever. Take that crossword and start doing it. Those are small things you can do, and just see if you're going to get better. Get out and take long walks or work out. Workout has been shown, exercising and getting your brain and those endorphins running through your brain has been shown to be beneficial for brain function and preventing things like dementia and getting senile, and especially at an early age. Because I know a lady who's 65 and has dementia. So when her daughters visit her, they're like, she's like, so the son had to move in. The son is like, oh, how are you? It's nice to meet you. She didn't know her daughters. But because for her, they have Alzheimer's in their family. So that's a different thing. It's genetic. So her daughters now are trying to learn what they can do to stop, like they have to take action and say, this is not going to happen to us. Can we do this? And they're also seeing therapists to get that fear out of their minds. So Grace, you're going to be fine. Just start doing some things to help yourself. Yeah.
That's very reassuring. Doc, I see we are running out of time, which I'll quickly wrap up. I see there's a question from Lindsay. I know you had a question. We'll start with you, Lindsay, if you can be very brief. And then we go to Mweni. And then we see how to wrap it up from there.
Hey Lindsay.
Hi, Dad. How are you?
Yes, Lindsay is those people. We need to have coffee and stop having our 1 hour, 2 hour conversations on phone.
Yes, I'm one of those people.
Hi. Yes.
Hi.
Karibu.
I am. Now, I'd like you to talk a little more about magnesium supplementation. I've been doing some research and I'd love to hear from you. What is the best magnesium to use when I am currently on menopause? Everything you talked about is happening to me because I was an early bloomer. So in our family, girls start their periods by age 7.5, 8.
Whoa.
Yeah. Yes.
Whoa. Yeah.
Yes.
Oh God.
Yes.
And now, I think one time we discussed in our group Super Mamas, and it's now considered that 8 is considered to be a normal age. Before we used to call it precocious puberty. Then now research is saying it's normal. I'm like, 8? 8? 8? Anyway, oh my God, Lindsay. Okay, yeah. So for you, you're likely to start early because you started early. So magnesium.
Yes.
Carry on. Finish up.
So magnesium, I got a doctor who mentioned about magnesium supplementation. The thing is what type of magnesium? Because there's so much out there on magnesium. So which one is the right one? Because I know some can make you have a runny tummy. Some can
yes.
Yes.
Yes. So unfortunately, okay, good. I'll disappoint you because there are many formulations and I have no idea which ones, but I'll get back to you on that one. There's actually, yeah, like you, I thought just take magnesium. So I walked into Health You, and unfortunately, in our shops, if you go to the UK and you go to a supermarket, those of you who've been to the UK and the US, they know what they're selling to you. If you go to Health You and you say, I want magnesium, they'll give you. Now, I learned the other day being on Instagram, this guy was saying, oh my goodness, even calcium, not all formulations are the same. So there's magnesium glycosamine, something, there's magnesium. So there are particular ones for particular needs. Lindsay, allow me to find out and then I'll let you know.
Okay,
yeah, but that one for sure, I'm not sure. But yes, there's a particular, and I heard it tested and sent on, it's magnesium, I don't know what it is, but it's a particular one recommended for menopause to prevent those running, irritating tummy. And then there's a particular time to take them as well.
Yes.
Remember that there's a particular time. Some you must take with the meal, others must be on an empty stomach. Even when we talk about like now I'm in Eldoret, and I was wondering why are Kalenjins anemic? This place has food. But then someone said they take a lot of iron, fine, the meat and the greens, but they take a lot of milk. Milk counters absorption of iron. Yes. I'm learning this. I'm like, when in London med school, happy. So even with, like, for example, if you're gonna take when you want to increase iron absorption, you're actually supposed to take a citrus fruit before 30 minutes before you take anything that you want, so that's your red meat and your greens. So we normally eat oranges when? After. You're not helping yourself. Yes. So let me find that out for you, Lindsay. I'll also post it on the Supermamas group, that we'll be getting the calcium, the magnesium supplement. Every research I've read about magnesium supplement and menopause, it comes highly recommended, because magnesium is an element that's so important in our cell function, and also where hormones are working. The other amazing source I learned of magnesium and I started loving, because I used to hate them like hell, was lentils. Oh my God, kamande siku hizi. I've learned how to make them the Indian way, and you get your really good source of magnesium, but you may need supplementation in menopause, especially if it's helping you with your symptoms. So you might find another person will take magnesium is not helping them. For you, if you find it's helping you, then get the right formulation and continue with it. So I'll find out for you, then I'll let you know, Lindsay. Paul, about that.
Yeah, thank you very much, Doc. Wrapping up, moving to Selena, she says, does it count if we read and do mental games on screen rather than on actual paper? I believe this can be, if you can, a yes or no question. Is it same, is it not? And then we can quickly, I think it's that. And then Lucia is asking if there's any effect of CS on our memories, having a cesarean section. Those two will wrap up our Q&A section, and then we shall wrap up. It is 8:33, which will be done in the next 7-9 minutes.
So okay, so I'll answer those two questions. But when Wambua is a very good friend of mine, so I'll kindly allow you to allow her to ask her question. She's a very good friend of mine. So CS and memory, I have not heard about that one. I've not heard about that one. I think a lot of it is speculation. We have to, also when you read a lot of Google, we as doctors have particular databases where we go to confirm what research people are doing. So I'll find that out for you, but I've never heard about that. I've not heard about CS affecting memory. Maybe in the long time ago days when they used to put you under and you're under general anesthesia. It's hardly these days that we put people under. You're using spinal anesthesia, you're awake, we're talking to you, your brain is awake. So for GA, maybe, but I don't think there's any research that I've heard about people talk about that. But when someone talked about it some time back, I was like, let me check the databases. Now, for us doctors, when we go to research, we say, there are particular databases. We say, these are the ones that have reliable research. So what they say is, if you say, for example, we say, antidepressants are good for menopause, yet the manufacturer did not make them for hot flashes. Let's do a research. So India do their research, America do their research. Then now these databases, they say, let us take these 500 studies that have been done on antidepressants on hot flashes, then they say, we looked at the data, we looked at the research, and we can confirm that this is correct. So the one for CS and memory, I've had a doctor talk about it, and I had it, I think, asked years ago, and there's no data to support that if you had a CS, or the more CSs you have, that you're going to have cognitive or memory issues. So no. When it comes to screen games, I think why I prefer off screen is because when you are off screen, it's better to do these games with other people, because you're able to interact with other people. Yes, there's some, I think I saw one which was being talked about on TikTok that I think guys who are above, it was being done on guys above 65, and they're actually saying yes, their memory was improving. Now that's really not in my area of expertise. I'll be lying to you if I say I know, but I guess if it's there, I guess maybe, but maybe one, do not do them before you go to bed. Make sure, I think they normally say 1 hour of screen time before you shut your eyes. Or I think this, yeah, but it should be about an hour before you please get off screen time. And then of course use the lowest light possible. But for me, I prefer interactive sessions whereby you're with other people and you're getting, interacting and getting, like your kids. If you've got children, you can play Monopoly, you can play Scrabble with them. That's one thing we did when we were kids, and my dad was very keen on. My dad used to make us read the newspaper for him. Oh my goodness. It's okay, but we love him for that. So CS and memory, I cannot confirm that because there's no database that proves that is confirmed, relationship or association between CS and memory. That's not been, it's been heard of, but there's no association that has been proven so far in hardcore research and evidence. The other question was, forgotten it.
No, actually, you've covered it. It was the one for when it comes to
the board games. Yeah.
So you have done that. Mweni.
Yeah. So Mweni, you're the last one to ask a question.
Mweni, go ahead if you can be brief.
Thank you so much. Hi, dear. How are you doing?
I'm fine.
Amazing presentation. I just want to say something that you covered. I'm a therapist, Christine, just so that for the record. But I think Mutindi said, Daktari said something that we need to begin to think about a bit more. Statistics show that women get Alzheimer's more than men worldwide. And that's because sometimes when you think about the way we live our lives as women, we tend to go through a lot of transitions and never process them. Women tend to go through a lot of losses and never process them. We keep being told that our chamas are social places and we are being helped, but many of them are helping us financially, but socially you will realize that even now, particularly in our generation, we have a lot more women saying, I am a solo, I fly solo, I don't trust people. And those are really issues that are carrying on from our emotional places that have not been dealt with. Currently, statistics are showing 70 to 80% of non-communicable diseases are actually as a result of unprocessed emotions. And I think it's time for women to begin to realize that we are not compartmentalized beings. Our head and our heart and our body and everything is all related. I'll give you this as a therapist. We begin to see that people are going through grief. You will not have your periods for 3 months, and we begin to wonder, how is that? But they are all completely related. When our bodies go through trauma, we experience physical symptoms, and we need to be able to understand that these are completely related because we are holistic beings. Thank you very much. I just wanted to make that.
Oh my God. I think Yani Mweni, oh God. All of you and Mutian just clap for her because Mweni, you're so right. Because I think there are things that we have been told. Thank you, Nalika. Thank you, everybody. There are things we have been told to normalize. We are seeing more women getting postpartum depression. And her friend tells her, like being pregnant and having a baby. Let me tell you, I don't have children, but I have seen my patients come and crack down because nobody had asked them, how have you? Doctors are not asking mothers, how are you postnatally? We assume because what are you coming to me at? You're struggling. So when you're so right, we do not process. And the same thing with menopause and perimenopausal, it is normal. What are you fussing about? So it is get through it without processing it. And that's what we have. And I think we saw our mothers doing it, and we don't want to look like Simpson Barbies going asking for help. And oh my, I can't, I think you have put the icing on the cake that menopause. I was watching Don Othoro. He was giving a talk on menopause last year, and he was with Amina Farah and Valentine Njoroge. And there's one thing they said: this thing is not normal. And so I watched, and the more patients I get, then I'm like, it's a normal physiological process, but you're not who you were. You're becoming like another different person. And when you compartmentalize that, because you're thinking, Niliambo, I'm supposed to go through it without talking to anybody about it, especially like a therapist. Because again, you may talk to your friends, and the conversation with your friends, conversations go like this. We started food, then what I came to talk to you about has gone out the window. But when you get targeted therapy, like what Mweni is saying, I think, Mweni, you've put the icing on the cake. She is also a grief therapist. When you lose a baby, oh my goodness, as those doctors oh, don't worry, you can get another one. She's not processed the one she's lost. And we become numb. And as doctors, it's like, yeah, you're 20 something. You can get another baby. I learned from her is you don't say that. Even she posts a lot on Facebook about what you don't say to someone going through grief. And when we think about menopause, it's almost, Amina says, it's almost it's a type of an end to something and a beginning of something that is a bit untoward. And you can't afford to say, this is normal and I'll get through it. I think if you're not talking to somebody about it, and I was surprised that depression is actually pretty high among menopausal women. So Mweni, thank you so much.
Menopause is a grief issue. Menopause is a grief issue because there's an end of life as you have known it, and now you're starting something new. You grieve the woman that you were. You're letting go of that woman. There's a symbolic loss that you're going through. You're wondering, now that I'm no longer able to have babies, I'm no longer able. Am I still female?
Yeah.
It's an
Thank
end
you
to
so
that.
much.
And so it impacts your identity. You begin to feel shame even as you sit among people who are so productive and potent, and you're looking at them and you're thinking, oh my goodness, I am so dry, and it's a real issue that is a stigma issue. And so many people will not even talk about it because they're embarrassed that they're going through menopause.
Yeah. Thank you so much, Mweni. I want to just thank everybody for being here. This was fun for me. This is what I love doing. I'm passionate about. And if you know something called a destiny helper, that has been Christine Casina for me. And I just want to hand it over back to you and say, thank you, my dear.
Oh, thank you so much, Dr. If we can unmute and make Dr. feel so appreciated, let's clap for her. Ululate. Thank you so much.
Thank you, everyone.
So very much, Dr. This was absolutely insightful. And speaking of just destiny helpers, for us, you've been that destiny helper for us this evening. And in our path, many of us, I believe, have interacted with you. And for those who haven't, you are one of the most amazing gynecologists I know. This has been really helpful. And I hope this information for most of you has been useful and worth your time. Our work as Supermamas is to connect you with people like Dr. Kakuti, so that as you walk on this journey as a woman, as a mother, that you feel supported, you feel empowered, you feel you can come into a forum and you are not alone. Because just as Mweni has said, crossing over into menopause, I actually saw online, there are even menopause therapists just to deal with that aspect of being a woman. It is a real struggle for some people. So we are so happy to have forums like this. We are so happy that you guys can come through and learn with us. And together we become a generation of women who are empowered. We have all the information as our dread, some of us will start falling off at some point. We know that we are still worthy, we are still beautiful, I can still shave off, and I'm still complete. That as you have your hot flashes, and sometimes you yell at your children, you know that there's therapy somewhere that maybe you need to consider, or supplements, or even medicine. We are now better equipped, we have more information. So thank you so much, Dr. for your time, and thank you all for joining. But just before you leave, allow me to call on my colleague, Miriam, to just share about the next event. And then also I'll just come back to share a bit about To wrap up about Supermamas, I know there are people asking about our Supermamas WhatsApp group. Then I'll tackle that a bit. And I think in another 2-3 minutes, which will be done. So Daktari, receive our love. Thank you so much for your time. And we hope to have you again and again. And for the people who are perimenopausal thinking of having babies, I hope you will help them deliver, that you have shared your number. We shall continue to seek you out for consultation. May God bless you. May God prosper you. Thank you, Daktari. Thank you. Miriam, over to you.
Thank you so much, Christine. Yes, thank you so much, Christine. Thank you so much, Dr. Mutindi. That was such an insightful moment. And we are looking forward to more. So on to our next event, that will be a business event, networking and learning and connecting. Come connect with us on the Thursday of 30th March. March 30th at 10 to 2 p.m. will be at iHit Kenya Event Space. That is Dennis Street, Road, Kilimani. And of course, we are going to dress up business casual, and we're going to have a good time learning about how to access funding for our businesses, for our own home finances. As we say, we are here to connect and learn more. So hope to see you. We'll be sharing the flyer on our WhatsApp groups and also on our social networks, so that you'll be able to come and connect with us. Thank you.
Thank you very much, Miriam. That will be our 81st event. Anybody who's in business, a mom in business, an opportunity for you to network, to come and learn, to come and share about your business. We are here to support you. 10 years on, 81 events. You cannot say that you do not have a platform where you can go and feel that you can just go share and feel that you are totally empowered and, like I said, supported. Supermama's WhatsApp group is open to anybody. As long as you're a mom, you can side chat me later. A lot of you have our Supermama's number. We'll be happy to add you to the Supermama's WhatsApp group. I see WhatsApp expanded its limits, so we are happy to have you on board so you can feel you're in a community of moms where you can continue to learn and grow. On the chat section, Miriam shared the Supermama's Facebook page. I believe Instagram is there. We always share all the activities we are doing in case there's anybody who wants to stay in touch with us without being in the WhatsApp group. So feel free to be checking out our Facebook page and our Instagram page, and you can stay informed. Ladies, it is 8:47. 5 years ago, you'd be dressing up to go to the bar. I know most of you right now. What is it to church? You have your, what is that thing we put on our heads? I wonder what our husbands and partners have to say. You have your stocking on. I can't even ask you to put your camera on. Some of you, I'm sure you've had dinner behind the screens, but what's important, you've made the time to join. We look forward to hosting you to another one. We are looking to grow our digital events because sometimes it's not easy for us to always come together for a physical event. But as we say as Supermamas, please continue to take care of yourself. Self-care is key. Information is key. Let's keep showing up and supporting other moms, and let's keep showing up and asking for support for ourselves. It's been real. My name is Christine Casina, and I look forward to hosting you in another digital event. Have a good night, people. Good night.
Thank you very much. Good night, everyone.
Bye, everybody.
Thank you. Bye.
Anybody with a it's a good time. Anybody with